There's a famous television program around when I was a kid, and they always began with a little quote saying, "Are you all sitting comfortably?" And then I'll begin. So I hope you're all sitting comfortably. Welcome to the second annual general meeting of Health PEI. My name is Kinsey Smith, and for my sins, I'm the chair of the Public Engagement Committee of the board, and I'll be your Master of Ceremonies tonight, and I was last year, and it was a great pleasure to do that. First of all, let me give you a warm welcome. Minister Currie, members of the legislature, community leaders, partners in healthcare provision, nurses, physicians, and other members of the staff of Health PEI who are here. Most of all, though, for all those islanders for whom Health PEI must provide a high quality of safe healthcare. This meeting is where information is to be shared and where there will be an accounting of the work that has gone on in the past year to continue the development of a single integrated healthcare program for this jewel of a province. The meeting tonight is province-wide. It's not just based on this site in Charlottetown. It's being broadcast live to Prince County Hospital, to the Western Hospital, and the Kings County Hospital. Those people who wish to join us at a distance at those sites will be there. It's also, of course, available on the web. It's being recorded, and it will appear on Eastlink at some future date. And translation services are available for those who wish to follow the proceedings in French. Just a word about the agenda. After greetings from Minister Currie, I'm going to introduce our keynote speaker, Professor Ross Baker, who's going to speak to the theme of quality and safety, which we have used as our label for today's AGM. We'll then move to the necessary reports on the activities of Health PEI. And then after that, there will be an occasion when we will welcome questions to a panel. And if you have questions, please take the opportunity to air them. Just to let you know, there are some feedback cards which may be in your package. If not, they're out in the foyer. Do please, if you have time, to make comments on them and leave them outside. We'll make a place for them to be left. Before we get down to the business of the meeting, let me first introduce the members of the board. Leo Stephen is the chair of the board. Gordon McKay is the vice chair and also the chair of the Compliance and Monitoring Committee. Marvin Clark, Kenneth Izard, Phyllis Horn, Amy Swallow MacDonald, Donna Murnahan, Jim Revel, Rhonda Smallman, who joined us this year, and myself, Kinsey Smith. So from now on, this is the meeting of your Health PEI, and I will ask Minister Doug Currie to bring greetings to us.
Thank you very much. Certainly would like to acknowledge some of my colleagues tonight, MLA Robert Mitchell, MLA Bush Dunville. I see MLA James Alward here, MLA Paula Bigger. I see Minister Henderson here this evening. I thought I saw MLA Colin Levy and MLA Buck Watts. Okay, great. Anyways, great to be here this evening, and certainly I welcome all of you tonight. I'm honored to be here this evening for Health PEI's annual general meeting, and I would like to welcome everyone joining tonight's AGM here at the Murchison Centre and our alternate sites all across Prince Edward Island. I commend our event organizers for recognizing the importance of engaging islanders from tip to tip and allowing islanders the opportunity to build on the vision of one island health system. I would like to recognize Leo Stevens, Chair of Health PEI Board, PEI Board of Directors, and Dr. Richard Wedge, the Interim CEO of Health PEI, as well as the rest of Health PEI board members in attendance this evening, and to say how fortunate we are to have such a dedicated group that represents communities all across our province. In yesterday's speech from the throne, we heard a renewed focus on strengthening our provincial healthcare system and putting the patient at the center of care in our health system. As Minister, I have a strong commitment and continue to work with Health PEI to provide the best access and quality care we can provide for Islanders from Tignish to Surrey. I would also like to send a special recognition to the former CEO, Keith Dewar, who has played a key role in the implementation of healthcare policy in the province. We were sorry to see him go, but wish him the best in his new career in Saskatchewan. Under Keith's leadership, we embraced needed system transformation to move towards an integrated, quality-driven health system in our One Island community. I also want to acknowledge who I think are the most important people in our healthcare system, and that's over 4,400 healthcare providers that provide care, compassion, and the skill to keep Islanders healthy and safe every day across Prince Edward Island. We know that Islanders are passionate about healthcare, and tonight's participation is another key indication of that. When it comes to health, we want to hear from Islanders. As Minister, I welcome your concerns, insights, and suggestions in ways we can build a quality system. Tonight, you will have a chance to hear about the positive work done by Health PEI over the past year, but you will also recognize the challenges that the system faces as we move towards a quality-driven, sustainable healthcare system. Lastly, I would like to welcome our keynote speaker, Dr. G. Ross Baker. Dr. Baker is a national authority on improving patient safety. He has served on the committee that recommended the creation of the Patient Safety Institute, and we are lucky to have him with us tonight to discuss safe, quality health care in tight financial times. Our healthcare system is constantly changing. New technologies, new challenges, new opportunities, but what remains constant is the desire to provide residents with the highest quality care that we can provide. Transformation and innovation are key to our healthcare system, but a consistent, clear overall vision for the province's healthcare future is also necessary for our sustainability. It is my vision and our vision that we use all our resources to their full scope, whether it be our healthcare professionals or our state-of-the-art treatment centers, so we can always provide Islanders with the healthcare services they require at every step of their lives. As Minister, I take this responsibility very seriously, and I'm confident that we have the accountability system and the governance structures necessary to ensure we create a sustainable system moving forward for years to come. Tonight's meeting is part of an ongoing dialogue on healthcare. Creating opportunities to engage Islanders in discussions around the future of healthcare delivery is an important step moving forward. I plan to continue these conversations with Islanders as we move forward, and thank you all for coming tonight. I hope you enjoy the rest of tonight's meeting. Thank you very much. Thank you.
Thank you, Minister Currie. As you say, we have the great pleasure of a keynote speaker who has come to us really very much connected with our concern about safety and quality. And that has been an overarching responsibility and concern of the board since its inception. Just having healthcare is fine, but it's got to be quality and safety that's part of it, otherwise you might as well not have it. I'll just tell you a little bit about Ross Baker, who I've met for the first time today. He's a professor in the Department of Health Policy Management and Evaluation at the University of Toronto. And together with Dr. Peter Norton, who was at the University of Calgary, he led the Canadian Adverse Events Study, which was published in the Canadian Medical Association Journal in 2004, but got international attention. Ross was a member of the National Steering Committee on Patient Safety, whose report in 2002, so we're going back a decade now, led to the creation of the Canadian Patient Safety Institute. And he co-chaired a working group on methods and measures for patient safety for the World Health Organization between 2006 and 2010. So there's a very international flavor to his experience. In October 2008, he published a book entitled high-performing healthcare systems, quality by design, and that's exactly what we're trying to think about as we plan Health PEI's activities. There are so many things about Ross that I could say, but I will limit the time I'm taking. Ross chaired an advisory panel on avoidable hospitalizations for the Ontario Ministry of Health, and this was released by the ministry in 2011. And he's also served as a member of the King's Fund in Britain, which had a commission on leadership and management in the NHS. And those who know of the King's Fund, it's very prestigious. And Ross brings to us experience of the world of healthcare, but the National Health Service is an interesting example on which a lot of Canadian things have been modeled over the years. So it's a delight to have you, Ross. Thank you for coming, and I will allow you to get on the podium.
So this is the moment every speaker dreads when he pushes the escape button on the computer, hoping that his slides are going to appear. But are you going to put them up for me, or am I going to have to do it from here? Okay. So don't touch the computer. Is that what you're saying?
You didn't know how tight the financial times were.
So we're just down here in the title bar. Yeah.
Ah. See, it takes an expert.
There you go.
Thank you very much. So let's just. So it's a great privilege and a pleasure to be in Charlottetown. I wish I was here longer, but it's been a great time meeting people and talking to people today, and I'm looking forward to interactions with you tonight. I'm going to say a little bit about this book that we wrote a few years ago, and try to put it in a broader context, because I think the lessons that we learned then have continuing meaning. And we wrote this from a perspective that was really meant to inform work in Ontario, but we've discovered that these themes resonate. And so I've talked about these issues in Australia and Sweden and England and across Canada. And you know, every place is different, but the reality is everybody has very similar issues. So although the solutions have to be crafted locally, I think the broader context of the issues that face us in healthcare today are quite similar across the globe. And one way to think about this, and I put this together before the hurricane hit New York and the eastern seaboard a few weeks ago, but it's the perfect storm, right? So what we face in healthcare, and it's been well analyzed, any report you read about healthcare touches upon these issues. So we have a healthcare system and a broader society that has helped us to live longer, healthier lives. But the price of that is that instead of having a lot of acute care issues that happen to people in their midlife, we now see a lot of chronic disease issues that are hitting people in later life. And so multimorbidity, multiple chronic diseases, is one of the signals of the current population that's looking for health care. The other piece of good news is that we have a lot of very creative, innovative people who are coming up with new technologies, new medications, new ways to approach healthcare, and that's all good, except that it all costs more money, right? So that's another element of this storm. And if you're like me, you want more, not less. You want better healthcare. You want to live longer, and so rising public expectations feed into this. But we have a system that has limited resources, and it's a system that is now stealing resources from our schools and from other parts of our society. So in Ontario, we're seeing a clear trade-off. I work in a university. University budgets have really been stifled over the last few years because the money has gone to healthcare. And so you have to ask your question, how do we balance off the demands in a modern society? We all want good healthcare, but we want a prosperous, educated society that provides the necessary goods to our population. And none of us want to pay more taxes, right? So that's healthcare's perfect storm. And you could get really dark and gloomy when you listen to that. But I want to tell you that I am an optimist. I think this is the time of the greatest opportunity I've seen in my career for healthcare to really work on improving the way in which we deliver care. Not everybody's there. And in fact, I put this slide up to suggest that there's really some choices right now. We could be a defender, which means that we sort of hunker down thinking that the storm is going to pass sooner or later, and then we can have what we all have always had. Or we could be a prospector and try to grow ourselves out of this, try to figure out ways to generate more money. Although I'd argue in our system that really is a very difficult thing to do because all our resources, basically all our resources are publicly funded one way or another. Or we could be what Miles and Snow in a book some years ago called an analyzer. That is, we could figure out how to do it better. Let's be more efficient with the resources we have right now, and let's be innovative and creative in ways that we maybe haven't thought about before. So the two choices are really to be a defender or to be an analyzer and look to the future. And so I want to look at those issues through the light of some of the work that we did in 2006, 2007, when we were asked by the Ontario Ministry of Health to go out and look at successful healthcare systems at a regional level around the world. Where were places that were showing that they could create innovative, quality enterprises at a reasonable price and sustain those over time? I'll say a little bit more about what those systems were. And then last year, with a colleague from Montreal, Jean-Louis Denis, we went back and we looked at those issues again, and we wrote another piece on this. So all this material is publicly available. Anybody's interested, I'll give you the links to get this material. So my wife called this project, which we called Quality by Design, she called it the Aeroplan Project, because we did a lot of traveling. We went to several places in the United States. We went to Utah to Intermountain Healthcare. We went to Detroit to Henry Ford Health System, and we went to the New England region of the Veterans Health Administration to look at what they'd done there. But we knew if we only focused on the US, that when we came home and summarized what we learned, people would say, okay, so you went to the US, but what can we learn from them? They have so much more money than we have. They spend twice as much, 3 times as much as many other systems do. So is that really a fair comparison? So we said, we have to go to England. We have to learn from what's happening in the best of the NHS. And so on the advice of some people in England, we went to Birmingham, and we studied the Birmingham Primary Care Trust and the hospitals associated with that. And then we asked Don Berwick, who's the American guru on quality improvement, where in the world should we go to see the best sustainable healthcare system that's hit the high mark on quality? And Don said, the place you have to go to is Sweden. You have to go see Jönköping, which is a county in Sweden. And because Don Berwick is a very reputable and trustable guy, we said, okay, we'll go to Sweden. And then we had an advisory committee in Toronto that was helping us with this, who were working in various parts of the system. And we told them we have these 5 places to go to. And they said, well, that's interesting, Ross. Actually, it's 6 because we went to see we went to describe a place in Alaska as well last year. But the advisory committee a few years ago said, Ross, are you telling us that there's nowhere in Canada we can learn anything from? And sometimes, the obvious doesn't come to you until somebody asks you a question like that. And we said, what's it going to say to the rest of the Canadian healthcare system if we say we're learning a lot from Sweden, the United States, and England, but we haven't actually asked anybody in Canada what's really good? So we did a process of asking people, where should we go in Canada to see exemplary regional healthcare systems? And we ended up going to 2 places. We went to Trillium Healthcare, which is 2 hospitals in the West End of Toronto, highly regarded by many who saw this as one of the successes in recent Canadian healthcare. And we went to what is now the former Calgary Health Region in southern Alberta. So we spent a week in each one of these places. We talked to a lot of people. We collected all the documents we could find, and we analyzed the results. And the goal of this was really to understand what these systems were capable of doing and what they did. What were the strategies that they carried out? What were the investments? And one of the just to show you what the focus is here, most of the work that goes on talking about healthcare systems talk about the Canadian system versus the US system versus the German system. And honestly, there's things you can learn from all those systems. But what we were really interested in was systems that were providing integrated care for a defined population, 300,000, 500,000 people. So thinking about PEI as a defined population receiving a broad range of services, and you get this idea about the kind of scope of the initiative we're looking at. We weren't looking at the team level within hospitals or within the community or the national level, but focused in this middle level, which I think is the place where a lot of change has to happen, because that's the place in which you can make decisions about what kind of services, what mix of services, in what location to serve what kinds of needs. Now, one of the criticisms we recognize people would make is, so how do we know these aren't just the lucky ones? These are the ones where people are healthier, right? It's easier for them, where the physicians and nurses want to be there because they're attractive places to be, where their populations are really quite engaged in healthcare, and so therefore it's really easy to get people to do things. And I want to tell you that that's not the case. So one of the places we went to, Henry Ford Health System, has their main hospital in the center of downtown Detroit. Now, the only reason why most of us would ever go to downtown Detroit is to see a baseball game, right? Because it was bombed out, literally bombed out in the 1960s. And although they cleaned up the mess, it has not come back. It's a pretty decimated place to be. And there's the big Henry Ford Hospital sitting in downtown Detroit, the center of this really excellent care system in the US. So this is not a situation of great advantage. And in fact, Henry Ford offers hundreds of millions of dollars of free care to the residents of Detroit every year who do not have health insurance, and they still balance their budget. So a big accomplishment for them, and not the only one. So I could give you an hour or more on the findings of this book, but I'm not going to do that. I'm going to say, if you want to, you can read the chapters, which each one describes a healthcare system, and I'm going to summarize what we saw across these systems as critical issues. So what does it take to make a high-performing healthcare system? I would say there's three kinds of issues. The first thing, and this is absolutely critical, is leadership. Leadership has to say what we want is the best possible quality system. Now, I know what you're thinking. If you go on the website of any healthcare organization and look at their strategic plan, they all say we want high quality of care. And then they have a list of 15 or 20 other things. And I'm here to say to you, the places that are successful, it's not that they don't have a couple of things that they're focused on, but they say the number one thing, the overriding thing, the thing we pay ultimate attention to is high quality of care. So quality and system improvement are at the core of what we do as an organization, not one of 27 different things. And the leadership wraps around this. It's not like many healthcare organizations where there's a chief nursing officer who's in charge of nursing, and her goal is to maximize nursing services. And there's a chief medical officer whose goal is to maximize medical service. And there's a chief financial officer to make sure the budgets are aligned. And there's a chief, you get the picture here, right? These people, these groups are focused and all together on this. And so leadership strategy is the critical piece. If you don't have that, what you have is a system where you have local heroes trying to make it happen in an environment that doesn't support them. So leadership and strategy, number one. And then if you look at the right-hand side, what we saw in these places was a lot of attempt to engage the workforce and to give them the tools and the ideas and to support them in making change better. So Sven-Olof Carlsson, who's this very engaging Swede who was the CEO for almost 20 years in Jönköping in southwest Sweden, used to say, everybody in my system has two jobs. And this is in a unionized environment, so he was well aware of the fact that what he was talking about. He says, you have the job that we're paying you to do. You could be a nurse, you could be a porter, you could be a doctor. He says, and you have a second job, and the second job is to improve what you do. And we're going to support you, we're going to teach you about that. So building capability and giving people the tools to do this is really critical. We have in Canada, I think, healthcare professionals who are as good as anywhere in the world, but we haven't always given them the tools to help improve what it is they need to do. Then the third column in the middle, which I call organizational design issues, really says what are the principal features of a high-performing healthcare system? And we could spend some time talking about this, but these are, I think, core issues. First of all, primary care is at the center of the system. Good primary care is the fundamental basis of a successful healthcare system. It's not that you don't want specialty care. You want that, you need that, but primary care is the core. And in Canada, we haven't done a good job of really supporting and creating that anywhere in this country, although my view is now that that's changing, and it's changing pretty quickly. And then integration of care across the various arenas in which care is given, promoting interdisciplinary teamwork, working together as professions and other healthcare workers, and creating an environment that supports people in making those changes. So now I've just saved you from having to go and read all those chapters unless you want to. But what I want to do now is take that and really focus in on that, because saying that in 2012 is not enough, because we all know that we have to make a choice. I said earlier, the choice is either to continue with the current way of doing things, which is a recipe for disaster sooner or later as the perfect storms washes over us, or to figure out how to do things differently, and different to give us higher quality, right? Better patient experience at the same or less cost. That's the challenge, the triple aim, which is what is sometimes described. And to do that, we need to change what we're doing. We need to find good ideas and test them safely in local environments and then scale them up. And then we need to create the capability within our staff to help identify and test those ideas, and the capability in our leaders to support the staff in that. And that's what I'm going to talk about in the next 15 minutes. And I want to tell you that I'm not the only one giving this message now. There are lots of people saying this. There was a report released in the United States, the Institute of Medicine, which is one of those very highly regarded bodies in the US, providing information to senior leaders across the US, and similar themes that they've identified. And 2 weeks ago, I was at the Ontario Hospital Association meeting in Toronto, and speaker after speaker talking about the necessity to think about redesign, innovation, transformation. So clearly there's a lot of energy around this. The question is, how do we do that? What do we do? And how do we support people in making this happen? To preserve what's good about our system, but to also change it in a way that's going to give us enduring value. So I'm going to talk about 3 ways to do that. One is around the core issue of redesigning healthcare. The second is, I think, the very powerful action that happens when you fundamentally re-engage with patients as a source of knowledge and a source of input in our healthcare system. And thirdly, on some critical issues that we need to address in all healthcare systems. And that has to do with high need, high use patients, and with care transitions, among other issues. So one of the really wonderful opportunities I've had in the last 5 years is to be a board member in Saskatchewan of the Health Quality Council in Saskatchewan. And it's a board of wonderful people. I mean, much like your Health PEI board, composed of people who bring great knowledge and expertise from their current or former lives to really share that and to work together as a team to build a better system. And one of the things we've done in Saskatchewan was to borrow a program from England, from the NHS, called Releasing Time to Care, the Productive Ward. And this idea is a powerful idea. It builds on lean thinking tools, so the tools that made Toyota sort of the giant of the automobile industry, until recent times at least, but translates them into healthcare and says, we have to help nurses and others figure out how to make work in our nursing units, our patient care units, more effective, higher quality, with reduced work stress. Because if you've spent time in a hospital lately, and I hope you haven't, but sometimes we have to, you know that the nurses are never stopping, right? It's an endless day, right? Often quite a long day as they run from patient to patient, trying to find the right information, the right tools, the right doctor, et cetera, et cetera, et cetera. And so what releasing time to care does is say, we should be reorganizing the place of care to make it easier for nurses and others to do their daily jobs. So they can work on professional nursing tasks rather than work on chasing the medication or the wheelchair or the IV pump or the missing physician who needs to sign a piece of paper before the patient gets discharged. It's a simple idea. It's a powerful idea. It's not an easy thing to do, but it's a very powerful idea. So not to belabor this, but just to give you a couple of examples what this looks like. So releasing time to care picks a number of critical measures of quality. This is not new stuff, but falls, pressure ulcers, medication issues, restraints, use of restraints. And so here's a couple of examples from a few hospitals tracing their progress over time. So this is from Prince Albert Parkland in the center of Saskatchewan, and the experience in one unit as they work to reduce the number of times that patients fall. Patients falling is a bad thing, and so most of the falls are preventable if we know how to do this, and nurses learn how to do this, but they don't always get the opportunity to practice what they learn. And restraint use. So this is from Regina General Hospital. So Keith Dewar will learn about the work of some of these nurses. He probably already has seen this great work as they work on this really important issue in psychiatry about chemical and mechanical restraints and the difficult issues that nurses face trying to manage their daily work without the overuse of those restraints. And part of what makes this releasing time to care really powerful is it engages and empowers nurses and other staff on the units. And it does that by creating tools for them on a local work basis to examine what they've done, to see what their progress is. And so you see that picture in the upper left quadrant. They call that the safety cross. And every day that there's a fall or there's a medication error, there's a little notation that goes up, a little dot that goes up, and the nurses huddle and they say, so how did that pressure ulcer, did anybody realize that Mrs. Smith was going to develop a pressure ulcer? And it's that focus on these critical issues that brings about local improvements in the visibility of these issues and the strategies that can be used to prevent them. So redesigning care, thinking about ways to make care differently within an organization, across organizations, I think is a critical piece of what we're doing. And there is a lot of work across this country and elsewhere that we can build on to decide what innovations can we have that make care better for patients, often at lower cost, right? And I won't spend much time on this, but Saskatchewan has escalated that work. They're now into a lean initiative across the entire province. Your eyes are not failing you. This is an impossible to read a PowerPoint slide, but it gives you an idea of the complexity of the work that they've done from the level of the Minister of Health down to the front lines in Saskatchewan. Everybody is aligned on certain goals, and the goals are captured in this strategy, the 4 elements of high-performing healthcare in Saskatchewan, which are better health, better care, better value, and better teams. I could speak for an hour on this because this is the most audacious experiment since Medicare in this country, I would say. And the work that's going on in Saskatchewan, strongly supported by the Ministry of Health, the Health Quality Council, and the regions, is going to offer us lessons across Canada. But I can't talk about it in more detail right now. So that's the first issue. It's redesigning and thinking about the tools and methods to redesign care. But who should do that? How should this happen, right? And one of the lessons that we have learned now is that in order to be successful, we need to put the patient at the center of the room. And so when we normally talk about engaging patients, we talk about engaging patients in their own care or in the care for your mother, your father, your daughter, or your son, right? It's around personal engagement. And now we're recognizing that there's a bigger game, a bigger opportunity, and that's engaging, as you are tonight, in discussions about what the design of our healthcare system should be. And one of the great stories that we heard, and it's now become a sort of legendary story in the quality improvement world, is the story of Esther in Jönköping. And like everywhere, Jönköping faced a challenge as they tried to reorganize care, balancing care that was being provided in the hospital and care that was being provided in the community. And they put the doctors and nurses from the community and the hospital together in the room, and they said, tell us how we should reorganize care so this will be better care for the patients. And what do you think happened? The doctors and the nurses in the hospital waxed eloquently about why it was so important to do this in the hospital and how good it was for the patients and really provided the highest quality of care. And the doctors and the nurses and the pharmacists in the community said, no, you have to understand it's so much better in the community, and this is why it's better in the community. And there was this, as we say, meeting of, not meeting of the minds, but meeting of these different views. And Mats Borstig, who's a lovely physician in Jönköping, had this insight with some of his staff. He said, you know what? We have to help people refocus this discussion. And the way to help them refocus is not to think about what's good for them, but help them think about what's good for the patient. And so they made up Esther. Esther, you see the description of Esther. Esther is 88 years old. She still lives at home, but she has some health problems, so she has to go to the hospital occasionally, and she sees a lot of doctors. But if we had Esther here, we would ask her, Esther, what's the best way in which we can provide you with care? And she would give us a view that was independent of the views of the doctors and the nurses in the community and in the hospital. And so they took that as a device. They said, let's design care for Esther. And every time we run into a problem, we'd say, well, what would be best for Esther? And they say that. It's a rhetorical device. Esther is a made-up person. It's a rhetorical device. But if you go to these conversations, I don't think they're acting. You go to these conversations and people are discussing what's the best way to design care for, they started with pediatric asthma, so children with asthma. What's the best way to design care for older people with congestive heart failure? What should we be doing? We have some choices here. They would say, well, what would be best for Esther? So really powerful idea. Well, they started this in the middle of the 1990s. They've been doing it for 15 years, and they keep expanding it. And I could tell some great stories. And one of the stories is about their dialysis program. And one of their dialysis patients a few years ago was a young man named Christian. He was in his 30s, but he developed renal problems, and he had to have dialysis. And so he went to the hospital, and I spent some time in the hospital getting dialysis. And then he went to see the head nurse, and he said, this is a good hospital, and this is a good service, but it doesn't work for me. And she said, what do you mean it doesn't work for you? He says, well, I can't hold my job. He says, I got to be in the hospital 3 times a week in the morning. I can't have a job and do that at the same time, and I want to have a job. Well, she says, well, that's just the way it is. He says, no, it doesn't have to be that way. He says, what if I gave myself my own dialysis? And I could come to the hospital, you could give me a key, I could let myself in early before the nurses show up, and I could start the machine, I'd be finished and go to work. Now, if you said that in most hospitals, the nurse would order something for you to sort of calm you down, right? In Jönköping, because they're so interested in Esther and this involvement, they said, that's an interesting idea, let's try it, right? And now they have a patient-run dialysis service, in the hospital. Now the risk management people must have been really nervous about this, right? You can imagine. But it's still working, right? It's a great story. And they have created a group of people, mostly nurses, that they call Esther coaches, who are constantly there to remind people about Esther, right? And to bring Esther into the conversation. So involving the patient changes the conversation, reduces all of the status issues we have sometimes, as we say. So who's the most important person in the room? Let's look at them first. If the patient's in the room, the patient is the most important person in the room, theoretically anyway. So that's the second issue, is about bringing the patient into the discussion about what kinds of services we want. And it's a long discussion sometimes, but it's an important one. And then there's this issue about what innovations do we need at a population level? Because I've talked mostly about organizational issues so far. And here's a great story. Atul Gawande is one of those really charismatic, incredibly talented people. He's an American surgeon, works in Boston in a big teaching hospital, and he writes a column for The New Yorker that is a very, very compelling read. You don't have to be a physician or a nurse to enjoy reading Atul Gawande. And he wrote a piece about 10 months ago about Jeffrey Brenner, who's a physician in New Jersey, who was overwhelmed by the patients coming into his emergency department. And it was an endless treadmill that he was on. And he said, you know what? There has to be a better way. We have to figure out how to get ahead of this. And so he went on his own initiative and looked at the data about who were these people coming in the emergency department. And he discovered something very interesting, that a very small number of these people, you could say 1% of the 100,000 people. So imagine all of PEI using this emergency department in Camden, New Jersey, which is not a highly desirable place to live. These are people who have many severe problems, low incomes, and no health insurance. So the emergency department is their primary care center, right? So he discovers that 1%, 1,000 of these 100,000 people were responsible for a large majority of these costs. And so that's interesting. I wonder if that's true of anywhere else. And one of my colleagues, Walter Wutchus, went with folks at ISIS, which has all the data in Ontario, and ran these numbers. And here's what it amounts to. So 1% of the people who use the Ontario healthcare system account for roughly 1/3 of the costs. 5% account for 2/3 of the costs. Well, that's really interesting. Now, do you think we're paying extra attention to that 1%? Well, one of the benefits of our Canadian healthcare system is we offer the same opportunities to everybody, equal access. But I would argue to you that we would be much better off paying a lot of attention to this 1%, or maybe even this 5%. If we could reduce the healthcare costs of the top 1% of the spenders in the system, in Ontario, we could save $750 million a year. I don't know what it's like for you, Minister, but in Ontario, that's real money. $750 million, you can do something with that, right? You can really make a big show. So it wouldn't be as much in PEI, but it's a substantial part. So now the issue is, what do you do? How do you deal with that 1%? That's 1 to 3%. Well, it turns out some people have thought about this for a long time, and the Kaiser Permanente people who provide care for people across the United States, one of the big care providers, created this population pyramid. They say we should think about the population in 3 segments. Almost everybody in this room probably is in that bottom purple triangle, right? People who are interested in their health care, they're concerned, they're watching their health, right? They're taking advantage of the services that are offered. You guys are the people for which the health promotion activities are designed. You're listening, right? Well, then the middle group are people who aren't listening, and they're often sicker, and they have a lot of issues to deal with. We have to do more to get them engaged. We have to spend some money to go out and figure out who those people are and what they need. So coordinators, outreach people who are providing this linkage to those people to get them into services, do a little more. And then there's the 1%ers, the 1 to 5%ers, it says on the top. They often don't know that they have a problem, right? They won't admit that they have a problem, and they're time bombs from a healthcare point of view. Sooner or later, they'll be in the emergency department, and then they're gonna have a long, expensive stay in the hospital, and they may go home, but you know what? A month from now or 3 months from now, they're gonna be back. And it's not good for them. It's not good for the healthcare system. And so when we were in Birmingham, we saw an example of this, Birmingham, England. I won't spend a lot of time on this, just to say, here's a compelling story. So we went to the teletriage area where they had these nurses who were trained to deal with some of these identified 1% people. And they weren't having a conversation like you and I might have about, so how are we managing our diets, or what do we think about the latest medications, or what did we see on TV last night that might be interesting for my mother or your mother, right? They were having a conversation trying to find the behavioral link that would get people interested in their own health. Get people interested in their own health. And so here's an example, South Asian male, 56 with diabetes, who stopped taking his medications because he saw a program on alternative therapies that said, there's something better for you. He didn't do anything else. He didn't start something better. He just thought, that's an excuse. I don't need my medications. I say it's not valuable. He's a time bomb waiting to happen. And they spent all this time developing a relationship with him so they could find out what he really wanted to do more than anything else was to go back to Bangladesh. And he was worried that he couldn't do that with his diabetes and his health problems. And that became the hook to say, well, what can we do? Can we work with you to understand what it's going to take? Now, here's the view. It's not the same rules for these people. It's different rules. We need to break the rules. So if we say everybody's entitled to, I don't know what it is here, 10 hours of home care a week maximum, and that's it. And once you hit 10 hours, sayonara, too bad. For these people, there are no maximums. What can we do to keep you healthy is the rule. And you know why? Because they're going to cost us an arm and a leg if we don't do that. It's better for them. It's better for us too. So that's the challenge. And the Ministry of Health in Ontario is just starting a new program where they're trying to find people who are willing to identify that 1% to 3% and really make a difference. And I won't say much about this. So we can talk about the high need, high users, and then we can talk about the areas of the system that we really haven't done a good job of creating effective care. And one of the areas is the transition. So when you're in hospital, somebody's responsible for you in hospital. And when you're in home care, somebody's responsible for you in home care. And who's responsible for getting you from hospital to home care? Nobody, right? So this transition, the handoff between hospital and home, or hospital and nursing home, or hospital and long-term care, is better in regional systems like you have here, where you have one system overlooking the whole thing, but it's not really good anywhere. So I chaired this panel last year in Ontario, and we went and we looked at the literature and we developed a series of tools, and we said there is no one answer to this. There's no one thing that you can do that's going to make it better. But the good news is there's a series of things that we've seen that if you do them all together will make a difference. And you see that in the blue boxes here. So better communication between the clinicians, the doctors and nurses who look after you in the hospital, and the doctors and nurses and aides that look after you in the community. And I know what you're thinking. Duh, how hard could that be? But the reality is, it doesn't happen, because it's not their job. Their job is to look after you before or after, but not in that transition. Preparation of the patient and caregiver. The patient's the only common ingredient here, so let's get them ready. And let's get a family member with them that gets them ready that knows what things should they look out for. What are the red flags that when you go home, if that happens, you absolutely have to call a doctor or come back to the emergency department. So that's really important. What tests, what visits are you going to have that we have to follow up on? So some hospitals now, they actually call you when you leave. Say, Mrs. Smith, you're home now 3 days. Any issues? How's it going? Right? Are your meds working out? Right? You have a visit next week, right? The hospital pays for that to happen, right? And this notion about making sure the medications are right is a critical issue. Older people are on astounding numbers of medications, and if you're looking after a parent or a grandparent, or if you are a parent or a grandparent, you often see those pill boxes, and the small ones don't work, so you have 2 or 3 of them, right? And then some meds are going to be the same over time, and other meds are going to change because you have different. It's a real challenging thing. So, we've identified the issues, and so the question is, what could we do differently here? Eric Coleman is this very bright, capable physician who works in the United States, and he said, you know what? What we'd really like is an electronic health record that everybody has access to, the primary care doc, the hospital, and anybody else. He says, but we don't have that. So what we're going to do is create a little paper record, my personal health record, and we're going to give it to every patient who leaves the hospital who's at risk of having a bad transition. And this tells them all the information they need to know. It's written down, because they're not going to remember it if we don't write it down, right? So in Ontario now, we're working on electronic discharges, which provide some of this information to people, and many now think this is important. But it's so 20th century, right? Give people a piece of paper that has all their stuff written on it. And I don't know about you, but I think we could do better. And I was really pleased. One of my PhD students, who's really a bright, capable person, is working with a team headed by Dr. John Semple, who's a surgeon at Women's College Hospital in Toronto. And they developed this smartphone app. And the smartphone app is given to patients who've had breast reconstruction surgery at Women's College on an outpatient basis, and then they go home. And things can go wrong, right, when you go home. So this allows the women who've had this surgery to every day answer 2 or 3 questions, and for example, say on a scale of 1 to 10, how are you feeling today? And then take the phone, take a picture of the incision site, hit a button, and it uploads. And the physician can come in the morning and he can look at every single patient he's had in the last 2 weeks. And if there's a redness or signs of some sort of infection, it's an instant sign. Call that patient, have them come in, right? Now, you know, this is not rocket science, right? But it's a wonderful use of new technologies to make things happen. So my message here, there's lots of other examples, is we need to be thinking about how we create innovation and learning in our community. And this is Joran Hendricks, who's a friend of mine, and he's the guy who's the chief of innovation at Jönköping, who really helps to identify things and helps other people to identify things that can make things happen. And I love to challenge people, so I always say to them, so who's your chief of learning and innovation? Who's responsible to make sure that you're on the outlook for new ideas, new things that could make care better, right? That mean that you don't have to sit in a chair and see a doctor, you know, wait for 3 hours to see a doctor when you could be at home doing other things and then communicating on your smartphone. So how do we make this happen? Just a couple of quick messages. One is we have to build capability within the system. I said that earlier. Give people the skills to make it happen. And Jönköping, again, they're training most of their staff to do this. And it's over time, they've built this energy around this. So everybody's asking the question, how could we do this differently? Well, what would be the best way to do this? And I keep going to Sweden, but let me use another example with S, and that's Saskatchewan. The Health Quality Council in Saskatchewan was delighted last year when Paul Levy, who used to be the CEO of a big Boston teaching hospital, wrote about them in his blog, saying, wow, what an innovative and exciting thing. And we had a quality congress in April, and Bonnie Brossard is the CEO, emailed Paul Levy, and she said, how'd you like to come to our quality congress and talk to us? He said, I'd love to be there. So it's this energy and excitement as people realize that they can do things differently and they can get engaged, and this is really palpable. And the last piece is coming back to this leadership. If the leaders aren't involved, then you have low level of activity, but you don't have system transformation. So it's the leader's job to get this done. And Jim Reinertsen, who's a friend and a real exemplary person, likes to quote this phrase: the currency of leadership is attention. The currency of leadership is attention. What does that mean? It means that what interests my boss fascinates me, right? So we look around to see what our bosses are engaged in. In healthcare, we look around to see what the leaders are paying attention to. If they're paying attention to finances, we pay attention to finance, balance that budget. But if they say quality is job one, that's the number one thing on our agenda, and you have to have a balanced budget, but quality is job one, then that's what they do. So there's a number of skills around this, and I won't spend a lot of time talking about it. But one of the most important skills is the opportunity to visit frontline workers. It's a tough job being a physician, a nurse, and a pharmacist in our system. People work extraordinarily hard. They're very dedicated. And we hear the stories about when things go wrong. We don't often hear the stories of the day-to-day work of people making things right in our system. And I'm glad we're recognizing some people here tonight in the meeting that you're doing here. But the leader's job, getting down and hearing the stories from frontline workers, hearing what's working well, and hearing what the problems are. This started in patient safety, where we did patient safety walk-rounds. And the senior leaders in organizations would get out. Some of them were a little nervous because they didn't really understand these issues very well. They went with clinicians who were more versed in it. But they all came away saying it was the best experience they ever had because it connected them to the work, the real work of the organization, what happens at the front line. So this idea about leadership visits is very important. So these are my 10 critical themes in transformation, and I'm happy again to point you towards the resources that we have that go at this in more detail. But I want to leave you with with a quote. It comes from Helen Bevan. Helen Bevan is one of these really extraordinary people who's worked for more than a decade in England. And the English story is a great story. So if you talk to somebody who emigrated to Canada in the 1970s or early 1980s, having worked in the NHS or having gotten care in the NHS, they would tell you horrific stories of long waiting lists and endless issues in the English system. And the English went pretty much from worst to first. Maybe they're not quite number one, but they transformed their system. And they did it partly because they increased the funds that were available in the NHS, but partly because they recognized they had to change the skills and the attitudes of people at the front line. Now, it's not 100% done, right? But they have created this enormous energy. And Helen was one of the leaders of this work. But as she said, you know what? We've only started this journey because the English are facing bigger challenges than we are, bigger financial constraints, and huge demands to keep moving their system forward. So I think we're quite lucky in this country. We have a lot of support from our political leaders. We have a great fundamental system. We just have to work to make it work in our own interests so we get the right care, as you say here, the right care at the right place by the right provider. So I think that's really important. So high performance happens. It's not just a myth. It happens across the globe. And we see elements of this in different parts. As I said, really encouraged by Saskatchewan work. But there's energy and enthusiasm about these issues across the country now. It's the most exciting time in my career in healthcare to make this a better system for us all. Thanks very much.
One of the things that Ross referred to was our interest in quality and safety, and Donna Monahan is a member of the board, and she's chair of the Quality and Safety Committee of the board, and she will tell you about awards which we are giving out this year for the first time, recognizing this in Prince Edward Island. Donna.
Thank you, Kinsey, and welcome everyone. It is really timely that we get to do this year, and it's wonderful when our keynote speaker identifies recognition of quality and safety as something that we really need to do. And yes, I don't have a slide. Okay. I want to probably start with, as chair of the Quality and Safety Committee for the Board of Health PEI, bring recognition to the board subcommittee, Dr. Mervyn Clark at the back and Ken Izard, as well as staff support from Garth Waite, Joanne Donahue, and Janet Hodder. So always a committee's work we want to recognize, so I get the fortune of being up here today. One of the things about Health PEI's Leadership and Excellence in Quality and Safety Awards is that this was a nomination process and people submitted names of people and groups who should be recognized. And it was a difficult process for our committee. And the evaluation criteria that was used was to evaluate all submissions based on the leads as in a caring environment framework. And that included things such as lead self, engaging others, achieving results, develop coalitions, and provide for system transformation. So each submission was evaluated on the basis of those criteria. And it gives me great pleasure to be able to give these awards out tonight. I'm going to ask Leo Stephen to come up as the chair of the board who will be giving the awards. But first of all, we will be giving out the group award. And I'd ask Martha St. Pierre and her team to please come up, and it's the group award goes to the group on collaborative model for diabetes care in physician offices across PEI. So I'll give them a moment to come on right up. as I read their names, they can kind of wave so we know who's able to be here tonight. The team included Martha St. Pierre, Provincial Diabetes Clinical Lead, Mark Spadell, Program Manager for the project, Linda Howell Coughlin, Kyla O'Keefe, Jana Korish, Libby Logan, Trish Collins, Michelle Hogan, Carmel Donaldston, Tanya Murphy, Joanne Sullivan, Mary Laura Cody, Kathy McFadden Arsenault, and Viola Murley. So these are the recipients. And I would like to take a moment. I'd like to take a moment as they're standing here just to give you a synopsis of what they presented. This award acknowledges teams who are making positive, sustainable changes across Prince Edward Island's health system in the area of quality and safety. This award was generated from a 15-month pilot project involving collaboration among diabetes educators with 17 physician offices to enhance client services, access to services, while decreasing the number of visits to the office, but also improving client outcomes. The collaborative practice model required coordination, support, education, a supportive environment, and a willingness of the whole team to mutually establish goals, to identify best standards of practice and processes to implement those practices that would improve diabetes management and therefore improve client outcomes. This team truly reflects providing appropriate care in an appropriate setting by the appropriate care provider that is coordinated, effective, and grounded by clinical best practice guidelines. Evaluation results reflect positive client outcomes, as well as requests from other physician offices that they will be able to provide this program as well. By working in real clinical settings and using a mutual learning and sharing model among the physicians, diabetes educators, social workers, office staff, and others. They were working together and the client outcomes were realized. So we'd like to congratulate the collaborative model for diabetes care in physician offices across PEI for the leadership you have demonstrated as a team and in relation to healthcare quality and safety for a PEI system transformation. Thank you very much. Our next award is an individual award, and we'd like to call on the award recipient, Kenny Martin, on chronic obstructive pulmonary disease. What's the project? Is Kenny, there you are? Great. Kenny Martin mobilized an interdisciplinary, interfacility working group to modify and initiate a PEI health system care pathway for chronic obstructive pulmonary disease. As the chair of the team, his leadership and professionalism were exemplary and were recognized as the driving force for the success of the team. His expertise in best practices for COPD, knowledge of the PEI health system, and his collaborative team building provided the essential ingredients for advancing best practices in clinical COPD care. His role modeling and engagement at all aspects of the work plan, his open and fair approach to the team, and consistent processes for ensuring open communication, as well as his organizational processes for planning and implementation of the project ensured that the team achieved the goal of quality and excellence. Kenny was described by the nominators as an exceptional leader, but not one to accept undue credit. His approach embodied integrity, teamwork, and a high moral and professional standard. He was described as someone who could make a grueling job fun who managed the highs and the lows by keeping the team grounded, yet gave time for discussions when tough conversations had to be done. He transformed the team's thinking of how to provide best treatment for clients with COPD across PEI. It was always about the patient and how we can make a difference in this patient population. So it does seem especially fitting this evening, Kenny, that you be awarded the first individual Quality and Safety Award for Health PEI. Congratulations.
I have a friend with chronic obstructive lung disease, and what he told me about the quality of that program was amazing. And the other thing is, diabetes is the cause of so much of the other health problems in the province. 70% of people on dialysis are there because of diabetes. And I don't know what the exact number is, but something like half the people who have coronary artery surgery have it because of diabetic arterial disease. Big problems. I think it's appropriate now to say thank you to Ross for the stimulus he's given us. This is exactly the way healthcare has to go. We have to be smart, we have to be realistic, we have to develop leadership. And it was so nice to have the counterpoint of having these young people come up and the idea that leadership is right there in our midst and we have to foster it. And that applies to the top end of the system and the bottom end of the system, because we're all equal when it comes to patient-centered care. Gee, I'm getting sort of evangelistic about this. But I am. Now we have to move on to the business issues of the meeting and give you an accounting for what has happened over the past year. And I'll call upon Leo Stephen to give the report of the chair of the board.
Thank you, Kinsey. Mr. Minister, members of the Legislative Assembly, honored guests, ladies and gentlemen, on behalf of the board, I want to welcome you, to the annual general meeting of Health PEI. And a special welcome for those on podcast and simulcast and our 2 of our 3 kids. For the Board of Health PEI, the past year has been a time of real substantial growth and accomplishment. Early on, board members realized how complex their work was and how much personal time and energy required to fulfill that role. Today's healthcare organizations, as you heard from Ross, are extremely complex. There are challenges on many fronts, and actually some days on every front. So as we heard again from Dr. Baker's presentation, healthcare leaders in Canada and around the world are innovating and making deep, transformative changes. But PEI is no different. The journey for the Healthcare Board over the past 3 years followed 3 key themes. First, as you can guess, our board is committed, I might even say preoccupied, with quality improvement and patient safety. Considerations of quality and safety are part of every discussion at every decision made at the board table. Now, the board takes its role as a champion of quality and safety very seriously, and indeed our commitment to quality is deeply rooted, in fact, within our organization. And as you just saw a few minutes ago, the board is very pleased, as an example, to launch the Excellence in Quality and Patient Safety Award as an indication of that commitment. The board is actually beginning to develop a national profile for its leadership in this area. Just recently, the Canadian Patient Safety Institute noted that the board quality and safety walking tours are indeed a leading practice in all of Canada. The second focus of our board is managing the healthcare cost curve against the rising demand of healthcare that that you've actually just heard about, but we'll just speak to in a few minutes. In fact, the issue is challenging all provinces and all jurisdictions, not just PEI. Our aging populations, increase in chronic care diseases, the introduction of new technologies and drugs are some of the drivers that actually relate to the increasing demand on PEI. In fact, during the first year, we focused on many of the change initiatives noted in our strategic plan that tried to deal with these major drivers. We put in place monitoring and reporting systems, and we established appropriate oversight mechanisms. Now, in the second year, our attention turned towards finding opportunities to improve system efficiency, resource utilization, and effectiveness. Our commitment to quality, however, remained as the overarching principle. The ED of Finance in her report will provide a concrete detail on how resource planning and allocation ties back to goals and health system. Then the third focus of the board is establishing a new strategic plan. We're now working, in fact, to develop a new plan. When the board was created in 2010, we inherited the strategic plan for 2009 to 2012, and we're now developing a new plan for the next 3 years. In that regard, engagement and stakeholder linkage will continue to be a priority. While there's been some activity and success in this area, I have to admit, and the board recognizes, that we need greater attention on this whole issue of public engagement. In the past year, we've held a series of expos, established processes for public presentations at our board meetings. We've held meetings at locations across the province and published our minutes. In the coming year, we're going to try a number of new things. We hope also to become, in fact, that these will become standard practice. The board has initiated what we call board-to-board conversations with other organizations. And these organizations have interest in healthcare and, in fact, have leadership roles in that regard. This linkage activity will be an important focus for the coming year. The board also intends to invite local groups to meet with the full board for a conversation about healthcare at our regular board meeting. This is in addition to the already established process for public presentations to the board itself. As well as these board-led initiatives, we will work with the department to, in fact, explore collaborative opportunities to enhance public education in the coming months. Finally, this has really been a year of change for the board itself. Mr. Keith Dewar, as you heard, our former CEO, recently assumed a new role in Saskatchewan. He provided superb leadership at Health PEI for many years. It was my privilege as chair to have worked with him, and we wish him well in his new career. At this time, a recruitment process for the CEO is underway. We hope to have a replacement in the next few months. In the meantime, we're very fortunate to have Dr. Richard Wedge as our acting CEO until a new CEO is recruited. Another area of change is in board membership. Our initial board members were appointed for either 3 or 4 years. For a number of our members, their first term will in fact be ending in March of 2013. Recruitment process to replace the retiring members will be launched publicly in the next few weeks. When you serve as a board member, the bylaws pertaining to conflict of interest indicate that you cannot serve as a board member if you work in healthcare. As such, we accepted the resignation of Geraldine McKendrick, who's now working in a position within the healthcare system. In her place, as you heard, Rhonda Smallman from O'Leary was recently appointed to the board. Rhonda is a retired teacher who brings an interest in children's health and is very active in her community. In closing, I once again thank you for coming out tonight, for your interest in Health PEI and the health of Islanders. Please enjoy the rest of your program. Thank you.
I do want to mention three people who have been particularly helpful in putting tonight's program together. Garth Waite and Brad Chatfield and Barbara Buell. Of course, all other members of the staff of Health PEI have been tremendously supportive, but these three people have had an awful lot to do with getting today set up the way it has been. The next speaker is Dr. Richard Wedge. He's taken on the very real and major task of being acting CEO, and we're very happy to have him in that role. Richard?
Thank you very much. Let's see if we can. Bring up things. So it's my pleasure to bring you the CEO's report for the year. Obviously, I've just kind of taken over this role over the last 3 or 4 weeks as Keith Dorr has left. So a lot of the accomplishments actually occurred with him. But certainly we're pleased to see the progress that's been made by Health PEI over the last couple of years. So the PEI is not different from a number of jurisdictions across Canada. We have a number of challenges ahead of us, and I've outlined 3 of them here. One is the increase in demand for services, and these services aren't really coming as most people think because of the aging population. A lot of these services are coming because we're doing so well as a health system, and as medical technology comes with the treatment of chronic disease. So a lot of disease that used to be a death sentence for patients are now essentially chronic disease, and that's things like congestive heart failure and AIDS and that kind of thing. So these increasing diseases are increasing the demand. We also have a non-sustainable rate of growth across Canada, including PEI, with 5 to 8% increases in expenditures, whereas the provincial revenues aren't growing nearly as fast, so it's consuming more and more of our tax dollars. The other big issue we have is our human resources are starting to retire in big numbers as the baby boomers started to turn 65 in the last couple of years, and we're going through the same issue on PEI and will be for the next 10 to 15 years. So we have a number of solutions that we're looking at, and that's to try and refocus on primary care and try and help people really at the front lines before they get into the hospital. So we're trying to move to a seamless system that coordinates the needs of these complex patients so they don't drop through the cracks as they transfer from one place to the other, whether it's the doctor's office to the hospital or into long-term care. We're also looking to some of these patients who have chronic health needs to be to managed better, so they're not coming into the doctor's office for episodic care just when they feel sick, but they'd actually have case managers that would be able to help them look towards certain outcomes. We're also trying to make sure that our health information systems are seamless so that everybody from the doctor's office to the hospitals can use the same information and the patients doesn't have to repeat themselves all the time. So just to remind folks about the Health PEI strategic direction that, as the board chair said, has been underway for the last couple of years, is that we really have a single integrated system of care across PEI. We want to make sure that it's evidence-based. We want to focus on improving patients' health. We want to enhance access, and we want to re-emphasize primary care, and as much as possible bring that care to the local communities. So there are really a couple of things we'll concentrate on, and that is the community-based primary care. To remind folks, we've set up 5 primary care networks across the PEI that are really based on geographical areas: West Prince, East Prince, Queens County, and Kings, although Queens is divided into 2. And these were developed with the goal of trying to ensure that everybody on PEI would have access to a primary care site within 30 kilometers of their home. The benefits include better access, of course, would be fewer hospital admissions. Another accomplishment this year was the provincial colorectal screening program for people with colorectal cancer, obviously, and that has been underway, and quite a few islanders, several thousand, have taken part in that once they turn 50 years old. We also have a stroke model that's gone into a couple of phases now. The provincial stroke unit that was established at the Queen Elizabeth Hospital a couple of years ago, and now the stroke prevention clinic for both follow-up and for prevention of further strokes. Some of the things around chronic disease strategy as well, as we heard tonight, the COPD project has been underway for a while. We're also concentrating on high blood pressure, diabetes, cancer, and chronic pulmonary disease, but we're also looking at better care for people with congestive heart failure. So as pointed out, the COPD story, the people with lung disease, bronchitis, and emphysema, has been a big success story that started at the Harborside Health Centre in 2011. So people with chronic lung disease like this, the reason we concentrate on is because they have, 5 to 6 visits to the emergency department per year. They have 2 or 3 admissions to hospital. Every one of their hospital stays are from 8 to 12 days long. So by having an enhanced self-management program for the patients themselves and working with them in primary care, we'd look at that, reducing the number of visits to the emergency room, reduced number of visits to the hospital, shortened length of stay while they're in the hospital, and then faster care when they get out of the hospital with their family physician. So some of the success stories at Harborside were, for example, the 30% reduction in emergency department use of the Prince County Hospital and a 50% reduction in repeat visits to the emergency department. So that translates, with 100 people at the Harborside Centre, that translates into almost 1,000 visits to the emergency room. So that's considered a fair success, and as you see with the award for Kenny Martin today, that's been spread out across PEI to a number of centres. So we've also done a lot of work in home care on PEI. I'll flip that one. So we're trying to do some work with our frail seniors to try and keep them in their home. As Dr. Ross Baker has pointed out, falls management is a very important thing. When elderly fall, it does lead to bad consequences. And we're trying to improve the case management of our frail elderly as well. So because of this renewed interest, our visits to home care are up, and we're providing more care there and trying to keep them out of hospital. Another success story is the palliative care program to try and bring palliative care drugs to the families at home so they don't have to be in the hospital. And that's led to a number of time being spent at home by up to 22% more than we used to do in the last few years. So the other factor we have on there is because of these extra time at home, it's actually 6,600 days of hospital days has been saved. And if you consider 365 days in a year, that's about 20 hospital beds every day would be occupied, right? So it does add up. A big success story here in the Charlottetown area has been the Queen Elizabeth Hospital Ambulatory Care Centre, and this particular program has brought together a number of medical programs, health clinics, including hemodialysis, specimen collection, special tests, for example, with ophthalmology, endoscopy, and same-day treatment. And this has improved the wait time as well for Islanders. Now, it's only really been open for the last month, but there's been about a 40% increase in visits to that area. So that's likely going to increase as time goes on. Our long-term care program with facilities for the manors, the government has been undertaking a lot of money into the manor program across PEI, and Health PEI has been working with that. So we have 3 open, the one in Surrey, the Colville Manor, the Maplewood Manor, and then the Margaret Stewart Ellis Wing in O'Leary that's partially open as well. The Somerset Manor in Summerside set to open in January, and then the spring of 2013 will be the Prince Edward Home here in Charlottetown. And then the Riverview Manor in Montague will open in 2015. As some people were saying, really what's happening with the manors, it's a whole different philosophy of care with patient-centered care where they live actually in neighborhoods within the manors. So it's another, I think, a big change for PEI. So the system-level improvement initiatives, as Professor Baker was saying, we've been focused on a lot of quality improvements at Health PEI. We have set up the Quality and Safety Council, and they're looking at things like medication reconciliation, and that's to ensure that the people's medications are are known to everybody when they transfer from one area of the hospital to another. So if you arrive in the emergency department, that everybody knows what medications you're on. When you transfer then to the medical floor, it's rechecked. It's rechecked again if you transfer to ICU. It's rechecked if you're transferred back home, so that people don't fall through the cracks and take medication where there's a lot of interactions. The infection control practices, there's been a lot of staff added into the infection control program on PEI, and then the patient safety program. There's been a number of both staff-driven initiatives as well as physician-driven initiatives. The Provincial Medical Advisory Committee has set up a medical quality committee that's looking at appropriateness of diagnostic imaging, appropriateness of lab testing, appropriateness of referrals to specialists. So they're looking at a number of those areas to try and help them with wait times and making sure the right patients go to the right provider. We have a number of advanced clinical access projects to family medicine that are underway in Montague and Cornwall currently, as well as the Harborside Centre in Summerside. And this is to try and make sure that every patient who has a family doctor, and we're trying to get, of course, to 100%, that they can get in to see their family doctor within a day or two for an urgent need, or within a couple of weeks for somebody who has an elective need. There's also been some work done on process engineering, what people call lean projects, as Dr. Baker was saying. And these are, for example, to try and improve the wait times between registering in the emergency department to actually seeing the physician. Some of the processing of specimens to speed up the processing time. And then some more work has been done on home care to try and improve the scheduling so more patients can be seen by the nurses there. We also have a collaborative model of care program that's underway. This has allowed a number of new providers to be added to patient care workers, for example, in the LPNs and the registered nurses within the system. And this has added about 78,000 hours of patient care at the bedside over the past year. The electronic health records is another one that we've been continuing to do some work on. With PEI, we have one record per patient on PEI, no matter what part of the system you're in. And when you transfer from one hospital to the other, that's the same record, can be read whether you're admitted to the Surrey Hospital and then transferred to the Queen Elizabeth Hospital. They can look up your records so that you don't have to repeat that. You don't have to carry around paper records and lose part of your records. So we're working on that to add what's called provider order entry, so that the orders can then be sent when the physician writes the orders to the lab, to allied health staff, or to the other parts of the hospital, so that everybody gets the record at the same time. So hopefully that'll come into play over the next year or so. So looking forward, there's obviously a number of changing diverse needs in our population. We're still working with our cost drivers and our pressures, and there are a number of social determinants of health related to the ability to pay for medications, people having the ability to pay for their food in order to keep healthy, that we need to continue to work on. But it's not an easy thing, and obviously change needs to occur at a number of levels, whether it's the patient's own expectations of what the health system can do for them, and what the clinicians expect out of the healthcare system as well. But Health PEI is committed to making these changes necessary to make sure that we have a system that's sustainable and supports the needs of Islanders. So over the other coming year, we hope to recruit a new CEO that makes my job temporary. We hope to do some more patient engagement as well to make sure that we're meeting their needs. As the chair said, we're looking at a strategic plan that hopefully will be ready in the spring. It will take us forward for the next 3 years. And then lastly, we're looking at the accreditation survey that we go through every 3 years is coming up again in September of 2013. So we have to prepare for that. So finally, I'd like to recognize the dedication of our staff. As people were saying, there's around 4,500 healthcare workers here in PEI, which is about 1 in 12, 1 in 14 workers on PEI actually work for Health PEI. And we're certainly proud of the work that they do, all the way from the Colville Manor in Surrey to the Tignish Health Co-op. We have a number of partners and stakeholders as well that are non-government organizations, for example, the Community Mental Health Association, who carry out a lot of our programming, and certainly we'd like to thank them for the work that they're doing. And I'll remind folks of a guest speaker that we had last year, Dr. Jeff Turnbull, who was the former president of the Canadian Medical Association, who felt very much that PEI was in a unique situation with 145,000 people and a very stable population, that we were an experiment that the rest of Canada is watching with close eyes. So that's the report of the CEO.
There is a flavor of constant development and constantly new things happening, and I think that's something that we owe a debt of gratitude to the staff. It's been a wonderful experience for those of us on the board to see how committed and involved the staff are in everything that happens. Teamwork seems to be an absolutely central part of what's going on, and building teams that work effectively like that group with the diabetes concerns is very important. Unfortunately, money is also very important, and we're coming to our financial report. And first of all, Scott Messervy from the Auditor General's Office is going to tell us whether we've done good or not.
Well, first of all, I'd like to thank Dr. Smith for the introduction. I hate to disappoint him, but I'm not going to give a credit score or anything like that on the audit. Actually, the taxpayers and the patients are the final judgment of how well Health PEI is doing. That being said, first of all, my name is Scott Messervy, and I'm the Audit Director from the Office of the Auditor General. I'm responsible for all financial statements conducted by the office, and basically on behalf of the Auditor General's Office, I really would like to thank the board and Health PEI for the opportunity to take part in your annual general meeting. My comments will be brief, so that's the good news. Bad news is I got to talk a little bit about the audit. Basically, before I do so, I would like to thank the board, especially Mr. Leo Stevens and the Compliance and Monitoring Committee, its chair, Gordon McKay, and management of Health PEI for the strong support for the audit function. And in particular, I'd like to thank Denise Lewis-Fleming for her dedicated work in dealing with auditors for an extended period of time. Her patience and response and attention to our needs is greatly appreciated. That being said, I also would like to acknowledge the effort put forward by both the financial staff and the audit staff in completing the audit of Health PEI. It is a significant undertaking, and they basically deserve a pat on the back for the job they do. They make my job a lot easier, for sure. Now, to the core of the purpose I'm here is the audit. First of all, what is an audit? An audit is basically a bunch of procedures that guys like myself, accountants, do to basically assess the financial reporting and reliability of the numbers that are presented in the annual report and the financial statements of Health PEI. It's not absolute assurance, but it is a very high level of assurance on the credibility and reliability of the information. Our audit was conducted in accordance with Canadian auditing standards, and as we've basically maintained independence throughout and have a number of ethical requirements to maintain, and this is all outlined in an engagement letter which we sign with the board of Health PEI, and we fulfill our engagement along those terms. At the end of the day, after we spend 1,000 hours or so auditing the records of Health PEI, we basically determined that the financial information presented by Health PEI in their financial statement is presented fairly, and it's a clean audit report. This is consistent with prior periods, which also received a clean audit report. So once again, I'd like to thank the board and management of Health PEI for the opportunity to partake tonight in your annual general meeting. Thank you.
Now I'll call on Denise Lewis-Fleming to give us the financial report. The work done over the past year has been enormous, and we're very grateful to her for it. Please keep in mind that the question period is going to follow shortly, so please have thoughts about questions you wish to bring up, either relating to Ross's talk or to other general issues. Denise.
Good evening, everyone. As I mentioned, my name's Denise, and I'm the Executive Director of Financial Services for Health PEI. So my report tonight is to speak to the operations of the healthcare system, and as established by the plan that was provided to us by the Department of Health and Wellness and overseen by the Minister. The financial statements that are in the annual report that I believe people received copies of is included in Appendix B. And it reflects only the activities of Health PEI. It doesn't reflect any of the activities related to any of the work that the department may do in their role, whether it be recruitment and retention, part of the wellness activities that are taking place. I'm sure people have seen the Go PEI and are trying to participate in some healthy living activities. That is separate from what you would see in our reports. The other thing I will say, and some people may breathe a sigh of relief, is that I am not going to go through the financial statements page by page that you see in this report. I'm sure I'd put people to sleep faster than they care to think about. One of the things I would like to remind everyone of is there are actually 3 key groups that are involved in the financial management of the healthcare system. The Department of Health and Wellness, of course. The Minister provides Health PEI with its final approved budget, and there's a lot of work and conversation that goes on throughout the year between the board, Health PEI, or the board, the senior management team, and the department to talk about the issues that come up, how we are doing in meeting our budget targets, and what we can do in order to address issues as they arise. The formal reporting goes on a quarterly basis, but there's regular discussions every month as part of the CEO's meeting with the Deputy Minister, and we also have reporting at our senior management team on a monthly basis to review our financial results. So in relation to where we ended up, for the fiscal year ending March 31st, 2012, the public is probably well aware of the fact that we did require a special warrant of about $5.78 million. It was as reported in the media this past summer. And as you can see here, that's reflected in that grant from the province. It was increased in order to offset those additional expenditures. Our revenues were up more than we expected. However, our expenditures were up quite a bit. And on the expenditure side, the pressures were in 3 main areas. Acute care was about $4.7 million of that pressure point. And acute care is, in this case, the PCH and the QEH hospitals. The long-term care side, we were experiencing some significant pressure there as well of about $1.7 million. And our pharmacare programs, the provincial programs for people in the public, the Seniors Drug Cost Assistance Program, some may be aware of, some of our high-cost drug programs, those were another pressure point during the fiscal year 2011-2012. Now on the revenue side, where the increases came from, we actually had received money from the province of New Brunswick for out-of-province liaison services. We have developed, I would say, a center of expertise in trying to repatriate our island patients back to PEI as soon as possible. And New Brunswick looked to us to say, can you set up a service and we will reimburse you for the cost to help New Brunswick achieve that same level of expertise. So it was nice to be recognized for that, and I think the physician services side at a province liaison office deserves a lot of credit for getting that recognition. We also did receive some additional funding for chronic disease projects. Some of them were mentioned earlier here this evening in relation to diabetes management or chronic disease or chronic obstructive pulmonary disease. Now, as noted on page 11 of your annual report, Our expenditures, about 65% of that $548 million that you see there are in relation to compensation. That amounts to about $354 million. So a significant chunk of our budget is spent on our health human resources. We also spend about another 14% on what I refer to as grants and sundry. And that really covers our pharmacare programs, our ambulance services, private nursing home contracts. And then another 10% on supplies was about $56 million. Further information on the types of expenditures on the compensation costs at the sundry can be found on note 22 of the financial statements, which are in Appendix B. These proportions are very, very similar to what we experienced last year. The categorizations that I just talked about are based on the Canadian Institute of Health Information Management Information Standards for healthcare organizations. So they aren't categorized the same as what you would see in the province's budget estimate books. They are actually categorized based on hospital expenditures that the CIHI Institute sets. Now this slide, I showed a very similar one last year, and it is to show to all of the interested public, where does all of the money go? I talked a bit about, is it compensation, is it grants, is it supplies, but people are also very interested in what types of services are we paying for and how much. You can see the vast chunk of our expenditures goes towards hospital services, nearly 43, or just over 43% of our budget actually. Another 13% to long-term care, and another 25% to medical services. And it's important to note that the medical services expenditures covers two pieces. It covers our in-province physician costs, as well as our out-of-province health services, which includes out-of-province hospitals, out-of-province outpatient services, as well as physician costs. And those out-of-province services cost about $44 million a year. On the hospital services side, as I mentioned earlier, it includes QEH and PCH. It includes all of our community hospitals, as well as Hillsborough Hospital, all the lab, diagnostic imaging, and hospital pharmacy services that are needed in order to keep everybody up and running, and our ambulance services and the clinical information system that Dr. Wedge was referring to earlier on when you have one electronic health record in the hospital. No matter where you go, the physicians have access to that same record, as well as the nursing staff. So each year, what I'm trying to aim for is to give a little bit more information or take a deeper dive into certain areas to help people understand what the money goes towards. And this year, the place I chose to focus was on our largest expenditure area, which is hospital services. So last year, we spent approximately $233 million on hospital services. And it broadly spreads out like this. And I wanted to note, before I go any farther, that this $233 million does not include physician costs, and it does not include our out-of-province hospital costs. So there's a substantial other piece of support that also happens for those hospital services. You'll see here the inpatient nursing units cost about $70 million to operate, and this is about 30% of those hospital expenses. You can see here there's about nearly 170,000 patient days. So that means, we count every day that you're in. If you stayed for 10 days, then we count that as 10 days of patient stay. During the year, we had approximately 15,900 admissions into the hospital. So if you take the very simple math, that means the average length of stay in hospital was approximately 10.5 days last year. Now, some people's stay are much shorter. Some people's stay, unfortunately, are much longer. And in Appendix A of the annual report, you will see the table on our key performance indicators that as a health system we monitor, one of which is how do we compare our actual length of stay to our expected length of stay. And there it notes that, unfortunately, our actual length of stay was about 3 days longer than what would have been expected, comparing ourselves to peer hospitals. You can also see here, we had about 10,500 surgeries that we completed last year, and those include both urgent and elective surgeries. Under the Ambulance and Canadian Blood Services grant, we do participate in supporting the Canadian Blood Services Agency. They also provide us with the blood product that we require. And our emergency department visits, I did want to note, have decreased from the previous year. In 2010-11, our total emergency department visits across the system were about 102,000, and last year we were down to 100,631. So that is an improvement and where we can start to see those projects such as the COPD project in Summerside, starting to take people out of the emergency department and treat them in the more appropriate place, closer to their primary healthcare provider and closer to their home. The final thing I wanted to note on this page is that, yes, there is administration costs. I know it always generates lots of discussion, but I did believe it is worth noting that at $4.31 million, this is direct administration costs for the hospital system, is only 1.8% of that expenditure, which is quite low when you see what those direct administration costs are. Now, another piece that people are often quite interested in is, what did you do with all the new money you received in your budget? For the fiscal year ending 2011-12, Health PEI did receive an additional $24.7 million in budget funding. Now, we always strive to want to address pressures by doing investments in new areas, but we have to take care of the existing services and the existing costs. For example, of that $24.6 million, compensation increase costs, so for our collective agreement increases, the increases in retirement costs that are increases in healthcare benefits, was about $8 million. Supplies and other contract increases, as you know, the price of fuel goes up, the price of medical supplies go up. That was about another $2.6 million, which is actually quite low for a budget increase. There has been significant focus on doing everything we can to minimize the cost increases in those areas with initiatives, whether it be effective utilization, renegotiating contracts to try and get better prices, and also, as you may have seen earlier in the fall, joining group purchasing organizations so that we can leverage our buying power. We did also receive some extra money for deficit funding because we had an issue in the previous year that we received some funding for. And then the things that you see on this slide, the investments here add up to about $8.37 million. So that's really where all the money goes to each year. We have to balance it out between taking care of existing services and costs, and then what do we have that we can focus on new investments. Quick few comments on the investments. The investments in acute emergency departments were really at the QEH and the PCH, and that was to update staffing ratios to reflect the increasing proportion of level 1 to 3 patients. Basically, they're sicker patients that are arriving and require more care. We'd talked earlier about the primary healthcare funding, where we were trying to enhance the primary healthcare networks and the collaborative approach to treating patients. Long-term care is another area where we did focus some investment dollars. About $1.3 million of this money that I note here is in relation to new long-term care beds that were put in that fiscal year. Now, half the money was for converting temporary beds that had been put in place to try and manage a pressure point, but then there was also new money for new beds. The other, about $660,000, was towards the opening of the new Colville and new Maplewood Manor. The new manors are designed in such a way to be patient-centered, however, they do cost a bit more money to operate, and that was where part of the investment went. We also did do a piece of investment in hemodialysis, and the bulk of this investment actually went towards the establishment of acute hemodialysis care on PEI. Previously, if an islander became acutely ill and was required a hospital stay, they would have had to been sent off island, in particular to Halifax, in order to be treated. because we couldn't support them in hospital on dialysis. That we made an investment in 11-12, and we can now bring those individuals into our hospital at the QEH and treat them there. And the uptake has been actually much higher than we anticipated, but it is a better quality of care for the patients and for their families because they're treated closer to home. And the final piece that I noted on there is there was some investment in ambulance services. There was some enhancement done in the West Prince area as well as in the Kings County area for ambulance services. Health system pressures. A lot of what I spoke to tonight is from the financial perspective. And you can see it's on the hospital side, we have financial pressures, on the long-term care side, and on the pharmacare programs. We have focused investments in trying to address hospital issues, focused initiatives strategically in order to try and address that, as well as long-term care. But I fully realize that the financial numbers do not always tell the whole story. There are operational pressures that can come out, which don't necessarily reflect in the numbers right away. We heard earlier about the demands of a growing aging population as well as a growing population with chronic disease, the need for community supports such as home care, and the number of elderly people who wait in a long-term or in a hospital bed because they need community supports to be put in place or they're waiting for a long-term care bed to open up. That growth in demand can also mean increased wait times, whether increased wait times for home care. It can impact over onto elective surgeries because we have to cancel a surgery in order to, because there's no bed available to put a person into afterwards. We continue to work every week, I would probably say every day, with the department to identify possible strategies to address these pressures. And in closing, what I do want to say is that, as you can see, there's been many pressures, and there continues to be many pressures competing for limited financial resources. Health PEI does have 4 stated goals: quality, equity, efficiency, and sustainability. We work to keep these 4 goals in mind as a senior management team, as we work with the board and the department to have a balanced approach to meeting the overall needs of the healthcare system as we allocate our expenditures each year. Finally, I do want to say thank you to the Auditor General's Office for the collaborative effort that we have put towards completing our audited financial statements. We are equivalent to about 42% of the provincial budget, so it is a substantial amount of work to get the financial statements done for this entity. I do also want to say very much a thank you to the board, and in particular the Compliance and Monitoring Committee, for their support, feedback, and guidance on financial planning and reporting for Health PEI. And last but not least, a thank you to my peers on the senior management team and all of the managers who strive to effectively manage the consumption of our financial resources while meeting very important patient needs. Thank you very much.
Now, I've tried to make it sure that we could have an adequate time for questions and for our panel. We are scheduled to end at 9. We might be able to squeeze on to 9:15 if people wish to go on longer. I hope there are plenty of questions ready. I'll ask the panel to come up onto the stage. So please ask questions of Ross Baker about the issues he raised and the other members of the panel as appropriate. So please, will you come and join us? Now, Verna Bruce helped us last year enormously with moderating the panel, and she's very kindly agreed to come and do so again. She will tell you about the rules and manage things from here on.
Thank you. So this truly is a provincial meeting. We have people across the province. We've got folks in Prince County Hospital, Western Hospital, and in Kings County. We have people joining us through the internet at home, and the meeting is being taped and will be broadcast later. We do have translation services available as well. So how to participate in the panel discussion, just a few of the ground rules. For people who are here at the Murchison Centre, we have 2 mics set up. I'd ask you to identify yourself by name and the community that you're coming from so that we have a flavor for the range of folks that are participating tonight. For people elsewhere in the province, there's a mechanism on the live stream web page that you're going to be using to send in your questions. And Brad Chatfield at the back of the room will be collecting those questions so that we have the opportunity to make sure that we cover the island like the do. And since it is a provincial meeting, I'm going to be alternating questions between the Murchison Centre and the people coming in over the internet. If you'd like to participate in French, we have the following kind of arrangement. If you want to ask your question in French here at the Murchison Centre, again, come to the mic, and Denny Morantz, a bilingual member of the board, will state the question to the panel in English. The panel will respond in English, but that's going to be receiving simultaneous translation, which will be available here through translation services, so it is a bilingual meeting in that sense. We hope that we will have a very open, honest, and respectful dialogue. And just a reminder that some questions you may want to ask may be outside the scope of the Board of Health PEI. So things like broad policy direction, the need for new programs, and some specific policy decisions are actually made by the government through the department, and that is a role for them. The role of Health PEI is to implement the directions that have been provided. It's also really awkward, and I'd encourage you not to ask personal questions tonight because of confidentiality reasons. And if you do have your own personal health concern or a matter of a personal nature, just kind of come up afterwards and we'll try to deal with those on a one-on-one basis. And in some cases, we might not have the answers right on hand, but we do have some staff here who can help out. And Health PEI has made the commitment to take the questions and follow up with information that can be provided. So with that, ground rules clear. We're going to open it up, and I would encourage people, I'll start with this mic in Charlottetown if there's anybody who has a question.
Thank you very much. My name is Dave McDonald. I'm the mayor of the town of Surrey. My questions are, I have two actually directed to Dr. Wedge. The main problem that I have, we had a great meeting. We found out all the nice things that are going on in health and PEI. We have some not so nice things going on. A number of years ago, we closed our health emergency service in the town of Surrey. At that time, your group promised us enhanced ambulance service to cover us. And for the first short time, it worked well. However, ambulances became more scarce in the area to the point where our firemen started becoming first responders. Now, last year, for example, we had 10 cases. We can live with 10 cases. This year we have 33. The total cost of that to our town is in excess of $7,000 or $8,000. Now I know in your budget that don't sound like very much, but in a small town like ours, that's a lot of money. And we want to know when you're going to do something to improve and enhance the quality of ambulance service so our first responders, our fire department aren't running around every second day answering a call. The second item I want to mention very quickly, and I don't want to take too much time, and it's not really personal, I'm not breaking the rules, but I personally am a diabetic. And in the town of Surrey for the last 6 years, I've had a medical doctor for 1.5 years. And I don't have access to Martha and her great team back here. I can't run into Charlottetown every day. I would like to know when your group are going to be able to provide appropriate doctor coverage for Eastern PEI. We really do feel somewhat isolated up there. Oh, and by the way, when you look for new members for your board, please realize that Kings County doesn't stop in Dundas. It goes all the way to East Point. Thank you very much.
So, Dr. Wedge, over to you.
Okay, I guess we'll start with the ambulance service. I'm not aware that there's any particular problems with the ambulance service. I do agree back in, I'm not sure the exact year, 2005, I think is when the emergency room closed in the Surrey Hospital. There was a commitment to add an ambulance to the community. I think there was a second ambulance that was there. And then around 2006 or so, we moved to the island-wide ambulance system with Island EMS. And at that point, I think the ambulance stayed for a while, but I'm not exactly sure what happens. But essentially what happens now is we have what's called dynamic ambulance response system, that ambulances, when the first ambulance moves out, another one from the Montague area or from Charlottetown moves up towards Surrey, and I think they have a depot in the Bridgetown area. So what we measure from the ambulance system is really around response times. And the response times we try to keep within in the rural areas is 22 minutes or so for a response. So obviously if the response isn't coming within that 22 minutes, then that is a concern that would need to be addressed, and we can bring that up with the ambulance staff at Health PEI. Now, the other thing about that is we've been trying very hard to encourage fire departments to become medical first responders, and many, and I'm not sure the exact number, but there's 30 or 40 rural fire departments who have taken that training towards becoming medical first responders because they see that as part of their role. And we are actually trying to encourage that. So you're right, there is some kind of a balance that needs to be done between relying on volunteer fire departments to go and having it done through the professional system. Whether it's a monetary thing, I guess maybe what you're talking about is each time they're called, there's some kind of a stipend to the firemen. Is that where the money goes? Yeah. Right. So I guess that is something that we can certainly bring up with government, though. I'm not aware. To be honest with you, I've heard from the Charlottetown Fire Department at one point around the number of calls that they had, but that has essentially disappeared under our new ambulance system over the last several years. So I haven't been aware that there's been any problems in other communities, but we'll certainly bring that up for you. Around the physician issue in Surrey, both ends of our island, Surrey as well as the Alberton, Tignish, O'Leary area, have been a struggle since I've been in there for the last 9 years to try and maintain physician services in those rural communities. It is very tough. We've had a number of physicians there. They've rotated through. I don't know how many times in Surrey, but I'll bet there's probably been 12 to 15 in the last 3 or 4 years that have rotated through. And unfortunately, just in the last couple of days, the two that were scheduled to come this fall have both pulled out and decided to stay in their home communities. And that's a devastating blow to us because we were relying on those folks. We had stopped the recruitment pending these arrivals, but the recruitment staff is now back at it again. But to maintain physicians in rural communities, it's no different. Even Summerside and Charlottetown are struggling in a lot of ways to maintain their physicians. They have to have a work-life balance that's appropriate for their training. They have to have the tools. So in rural communities, if they're not interested in practicing in a small community without a whole lot of specialist support, it is very tough. Yeah.
Okay, don't see anybody at mic 2, but we have 2 mics going, so I'll go back to mic 1, and then we'll take a question from outside of this room. So go ahead with your identification.
My name's Leo Garwin. I'm from Charlottetown, and my concern, I took part a couple of months ago of protest that was in Halifax against our health cuts. And the federal Prime Minister met with the federal health ministers and didn't sign a health accord. And now the provincial governments all across Canada, they have to take this responsibility. My question is to Donna Murnion, and that's a good idea for the provincial government to take on this role, and the federal government is getting out of this role.
I guess to try to, if I'm clear on your question, what it is about is whose responsibility is health, and is it a federal or a provincial? And my response as a board member is that I think healthcare is a provincial jurisdiction for most of what we do from an operation perspective, but the federal government has a key role to play as well. And I believe we have to continue to negotiate what that looks like.
give you credit. Keep pushing, because Harper, it seemed, want to get out of responsibility for any do with healthcare or whatever. So thank you.
Thank you. Okay, we're going to go to Brad, who's got a question coming in from somewhere in PEI.
This question is from online. What is Health PEI doing to increase awareness, particularly among physicians, of Lyme disease?
Who wants to try that one? Or do we have somebody else who wants to?
I'll take a stab at it.
Okay.
But Lyme disease, of course, it's a tick-borne disease for those in the audience that are not aware. But it's coming because of climate change. It's moving further from the northern United States in towards Canada. We do, with the Department of Health, the epidemiology unit and the public health unit, try and monitor any tick-borne illness that does occur on PEI. When it comes to physicians, there are a number of ongoing educational seminars that are done around emerging trends and diseases across Canada, and we do encourage all physicians to have ongoing continuing education courses as part of their privileging process at Health PEI. Now, whether or not they attend a course that mentions the treatment of Lyme disease or tick-borne diseases or not is kind of hit and miss. But certainly once the disease ever makes its appearance on PEI, there would be ongoing bulletins that would go out from the Medical Society as well as the Chief Public Health Office.
Thank you. So next question from Charlottetown, mic number 1.
Hi, my name is Sam White. I'm from the PEI Reproductive Rights Organization. I don't know if you guys remember me from last year, but I just thought I'd come back this year. The theme for the meeting is keeping Islanders safe while making cost-effective decisions for both our government and the residents. And as well, it's realizing your new vision of Health PEI focusing on primary services and to quote Dr. Wedge, make those services as much as possible, bring those services to local communities. Island women and girls are harming themselves using physical force or even ingesting chemicals to try and induce abortion because it's simply not in reach for them. PEI already owns the equipment to perform abortions, and they're already being performed here in the case of incomplete miscarriages. Please explain to me how it is safer and more cost-effective for both island women and for our government to make residents travel and pay out of pocket to access equipment that we have sitting in our very own hospitals. And as well, please explain how this is in line with your vision of focusing on providing primary services as close to local communities as possible.
Okay, so who wants to take that one?
Oh, if I could just direct it to Dr. Wedge, but I'd also like to get your innovative insights as well, Dr. Baker.
Yeah, well, certainly abortion services was a big topic last year, and as you know, Sam, we had this chat last year, and we also met, I think, with the minister at one point during the year. But abortion services are an item that is covered under the PEI Medicare plan. I do agree it's not provided locally, but it is provided on a regional basis, and access to that service is available to women who do decide, in concert with their physician, to have it done. But it's treated the same as any other out-of-province service, whether it's done through the cardiovascular surgery or transplant surgery or neurosurgery.
Can I just interject for a second?
Yep.
Abortion services is considered a primary service through the Canada Health Act, and so in that way it's very different from those other services.
It's a service that's insured under the Canada Health Act, and if at the end a physician came forward and wanted to perform them on PEI who had the correct training, obviously they would have access to the resources on PEI. But the Premier of the province has told us in Health PEI that he wants to maintain the status quo, and it's our role to implement the health plan as given by the government. So you're right, it could be done in PEI. We do have physicians who know how to do the procedure, but we don't have any physicians who are interested in doing the procedure on PEI.
So Dr. Baker, I don't know if you want to try this one or not.
It's very tough for a guy from Toronto to jump into a local issue.
It is. And again, you don't have to.
Yeah. I mean, I would say, that you're putting forward a challenge to the system that is based on reasonable assumptions, but you're going to have to find ways to bring people into the system that are going to help you out because the existing services aren't meeting your needs.
Is it not the role of Health PEI to make sure that we do get the best possible care and have the best access that we can to those primary services, regardless of politicians' roles in wanting to keep their seats in government?
I think what I'll do, I'll let the chair of the board, Leo Stephen, take that one, and then I'm going to move over to Mike too.
Well, I think you're discussing really two aspects of the question. What is the medical requirement versus what is the political statement? In terms of medical requirement, there are 60 procedures done a year off island. Can they be done on island? If there are no physicians that take up the procedure, then there's not likely to be a service provided. Secondly, I know from my past experience that these services have to be well established. There's security issues, follow-up issues, and the centers that provide these services are, in fact, created purposely for that. So I think your comment is more around the political aspect, and I would suggest that if there are medical issues that we're not aware of, that those should be raised with us. But I think at this point you're asking about really a political issue.
Thank you. So over to Mike 2 in Charlottetown, and then we're going to go back on the road again.
Yes, thank you. My name is Alvin Keenan. I live in Surrey. My profession is I'm a potato grower, so I'm out of my element in asking much about healthcare. But there's always some comparisons. And one of the things that yes, like healthcare in rural areas, dialysis in rural areas, what have you. That's why I'm here. But genetic drugs, and I think about, and we wrestle with the same thing in agriculture. The R&D is not paid when we don't use brand name products, and the cost of developing, a new drug for healthcare. I'm shocked when I hear some of the numbers. I believe it's, the $1 billion, and spelled out with B, and then so I know there's funding available from drug companies and for research and development on how we can administer health care. And I'm just asking that I know this is a little political, but it's also the room is full of healthcare workers and tonight. So I'd like us to take that under advisement in the future and take a strong look at where we're going and keep a high percentage of our drugs in the brand name, so we can so we can investigate better ways to raise funding for our health care. I'm going to leave it at that, and thank you.
Thank you. So does someone want to try to respond to that one?
Take a stab at it. I agree. I mean, there's obviously a role to play for the brand name drug industry, and they do provide a lot of research and development in Canada and around the world. So as with any healthcare system where you're trying to balance the budgets kind of thing, is to try and make sure that you provide some new innovative drug technologies, as well as rely on some of the ones that have been around a long time and have been well tested. So really, I guess my way of looking at it is under the patent system, the brand name drugs have about 17 years to make back their research money. And at that point, it's then available to everybody on a more widespread basis. So we do try and add some new brand name drugs to the system every year. But in addition, we have to make sure that our generics are well used once they become available, in order to be able to add a lot of drugs to the system. We can't rely all on brand, so we have to balance that all the time.
Thank you. So we're going to go to somewhere in PEI.
This question is from Corrine on the web. When will Islanders hear about the exciting provincial dementia strategy received by government and Health PEI in June 2011 And what dollars have been allocated in the budget to support Islanders living this journey of dementia?
So who would like to do this one?
Okay.
Dr. Wedge again?
The dementia strategy is an important thing, obviously, as our population ages, and in some of our communities, the population is aging even faster than the calendar year, and that's because a lot of the young people are moving out of certain communities. So this dementia strategy is designed around trying to make sure that there's early recognition, that there's proper treatment that occurs, there's supports for the families in their homes, and then when they get to the point where they need to be institutionalized, that they're in a safe environment. The new Colville Manor, the other manors that are being built are all designed around having safe places in their public manors for dementia patients once they get to that point. I'm not sure the exact number of dollars that have been put into the dementia strategy, but there has been a focus as we renew the system towards that. Denise, do you know of any money that's specifically been earmarked towards dementia? No, but there certainly have been additional nursing care and resident care workers that have been hired into the manors to support dementia patients. But I guess we'll have to try and get back to you with exactly how much money has been spent over the last few years, whoever the lady was.
Thank you. Okay, so now we're going to go back to Mike 1 here in Charlottetown.
Name is John McLean, and I reside in Morel. For those in attendance that do know me, they kind of know a little bit of my story. Was injured 3 years ago, went to the ER, never even got seen by a doctor. Over a dozen physicians on PEI refused to treat my severely injured spine. Just less than a month ago, I received in Moncton in a very aggressive surgery, 2 lapidectomies, spinal fusion, titanium rods, spacers. Yet here on Prince Edward Island, they basically said it was in my head. Even after the MRI, the doctor that ordered the MRI completely dismissed the MRI, said this patient does not have these symptoms, and that the MRI was inaccurate. What kind of steps are you guys, as the board, trying to make to prevent this from happening to the next person? As literally I went to every walk-in clinic, ER, refused medical treatment. They just wouldn't look at it.
Okay, so who would like to take that question? Donna.
I think, John, I'm not familiar with your case, so it's good to hear what you're talking about and raising issues about the type of care that you feel that you received or did not receive here in PEI. The process by which we have asked, or I don't know if you've had an opportunity to complete a complaint about the care that you received.
I tried numerous times to make my concerns aware to this board. I thought they were. I guess they were not. I have filed my process with the college. I filed my process the QEH, and I thought with Health PEI. I've attempted numerous times to meet with the current Minister of Health and the previous Minister of Health. I've been told that I do have a meeting with this minister after the fall session. The last minister refused.
Okay. Well, based on that, I would suggest that we probably need to have a conversation offline and have a dialogue with you, and would appreciate that.
Thank you.
Thank you. Okay, so
I just want to add too, though, that if this could be a quality issue. We don't know enough about your situation, but one of the board's objectives, as you heard, is to ensure that we review overall what we call sentinel events, or events that cause harm to a patient. We're not aware of this one. We're not aware that of what this event was. If you want to make us aware, it can be done through the CEO if you wish to give them a synopsis of what that event was. We will look at it.
I did have a brief phone call conversation with the new CEO about this story.
Okay.
Yep.
There may be
Dr.
more
Wedge.
that to be done on
Yeah, I think-
offline, so if you're
Sure.
okay, we'll do it that way. Okay, over to
Thank
Mike 2.
Hello, my name is Bruce McIsaac, and I'm resident of Charlottetown. My concern is with the, and I must say, I must thank Dr. Baker for his presentation. It was a step outside the box, if you want, that we must look at new models of care. My concern is with the addiction system in Prince Edward Island as a whole. It's been something that I've been dealing with both as an alcoholic and as a drug user and so on over the last 35 years. Thank goodness I've been clean all those years, but in the meantime, we've been dealing with the different so-called models of care. Does the board, or is the board intending to revamp, overhaul, whatever it may take to deal with addictions on Prince Edward Island? Now, most of you people in this room are affected by addictions. It is probably the most single expensive cost that we can endure, and I can say that by our criminal system, by people showing up in the ER, by families being disrupted, by social services, and so on and so forth. We all have our stories. We've all heard different types of incidents. My concern is that the present system is not working.
Okay, so who on the panel would like to address that one? Dr. Wedge, looks like.
Okay, I'll will comment a little bit. I do agree that both our mental health and addictions system are very resource intensive on PEI, and there are a number of problems that have stemmed mainly from drug addiction as opposed to alcohol addiction, which traditionally has been the focus of the addiction treatment center on PEI. But that has shifted over the last several years. I'm not sure if you're aware, but the government has instituted a review of mental health and addiction services on PEI, and it's currently underway as we speak. I'm not sure the exact time that's going to be completed, but I'm going to say roughly the spring of 2013. Yep, the spring of 2013. So there will be some public discussion around that review that's underway. I'm not sure if that really answers your question or not.
It does, and I appreciate that much of the answer. My concern has been that there has been far, far too little consultation, if you want, like what Dr. Baker said, with the patient. We have to engage families. We have to engage people in the process. It's no good if the system is just going to review itself. And that's what's happening with the addictions review. You're reviewing yourself. I don't know, but I don't want to make this a political issue. I don't want to make this an embarrassing issue for anyone whatsoever. I would like to see the board, if anything, you are an encourager. Dr. Baker gave good ideas that the Department of Health, the minister, someone take the initiative to treat addiction in its proper form and give it the attention that it needs.
Thank you. Okay, I'm going to flip to out of province, Brad, or out of Charlottetown, Brad.
Question from Andrea online. I have personal experience with New Brunswick's telecare program and strongly believe it is a program Islanders could benefit from. Is PEI implementing a provincial telecare program?
Okay. Panel. Leo.
Do you want the answer is that I think we continue to look at various approaches that will help us to extend healthcare into the home setting. We have looked at other provinces, one of which you've just mentioned. The experience that we find is that we will then have to deal with issues of liability. If the service is provided off island, the advice given over the phone, in fact, is advice from another province, another jurisdiction. So we'd have to be looking at the legal issues. Can we provide it on the island itself? I think we had looked initially at the cost of providing telephone-type triage services. At this point, they don't seem to be warranted. And I'm not sure how much they would be used on the island. I think the focus that we've had is, in fact, to try to establish as much as we can primary care contact. That is our main focus. So I agree. I think I've come from a province that has a service available. It is useful to a limited extent. Very often what the advice is very high level, if you will, and then the advice from there is go see your doctor, go see your emergency physician.
Thank you. Okay, we'll go over to Mike 1 in Charlottetown.
Good evening. My name is Nathan Bushy. I'm from Surrey. I'm a dialysis patient. I have a question. Well, I wish that the minister was here to hear this, but I guess he's not. I'd like to direct this question towards Acting CEO Dr. Wedge. Force of habit. Anyhow, given the fact that dialysis is a life-saving service, was the decision to centralize the dialysis units and force elderly patients to drive over an hour in a very weakened state a difficult one? And if so, where is the rationalization?
Yeah, well, I'm sure as a lot of these things they are difficult decisions, obviously not made lightly. But at the end, we need to try and provide the most care we can in the most efficient manner for most people. So whether the sites are in 4 sites or 6 sites or 2 sites, I guess at some point that decision has to be made. It is very tough to have a service in a community and then remove it. It's a deep sense of loss of those communities and the people who are
telling me.
Yeah, and the people who are receiving the service there, they've obviously changed their life to either move to the Surrey area to receive the service or happen to live in Surrey before it started. The biggest problem that I personally have with some of the sites is the people who have a number of medical problems, not just a straightforward dialysis problem. And if they have a need for heart disease, diabetic control, they have to have access to specialists. They have infection control issues. It makes it very tough to operate out of a small unit like the Surrey unit. So
are you going to send doctors home with us then?
Well, wouldn't that be nice? Yeah.
This is a chronic disease, as I'm sure you're aware.
Yeah.
It doesn't stop once we finish dialysis. So the fact of doing dialysis in Charlottetown really I see no benefit to that.
Yeah, so we need to look at some things. As you're probably aware, the government is doing a review of that decision around the 4 sites. But as Dr. Baker points out, the people in Jönköping in Sweden, and Christian, who was a worker in the Volvo car industry in Sweden, he was very innovative towards the self-dialysis program, and that is probably something that we need to look at on PEI.
Right, and actually I did mean to bring that up. So if Christian can do it by himself, then why can't I have my nurses in Surrey do it for me?
Yeah, so what has to happen is people have to be trained. There are issues. If you read the whole story of Christian, he kind of went through a whole transformation over a few years. It wasn't just a simple, I want to do it, get taught in a few hours, and then that's the end. But there was a process that was around where he was trained similar to a dialysis nurse, and that dialysis nurse was very supportive of the program. He was very bright and capable young man who went on to do his own self-dialysis, and to complete the story, he actually left his job and went out back to university, and he's now a dialysis nurse himself.
Well, that's good.
So,
that's good.
So it is quite a story. Now, that being said, he does treat and teach a number of patients all around Sweden, and in fact, all through the European community on self-dialysis programs. So
This is nothing new.
Right.
Right.
But again, it's something that has to be looked at in PEI. And
Right.
it's not the only thing. I mean, we could look at a nocturnal dialysis program, for example. Or,
I think that's a good idea.
Yeah.
Okay, thank you. So nobody at mic 2, so I'll flip back to mic 1 in Charlottetown, and then we're going to go back to Brad and out of Murchison Centre again.
Hi, thank you. Good evening, everyone. My name is Matt McFarlane, and I am currently serving as president of the PEI chapter of the Kidney Foundation of Canada, and I certainly would like to adopt the comments of my friend Nathan on behalf of the foundation in expressing concern about the state of the dialysis units excuse me, in Prince Edward Island and the potential of their closure in the Surrey and Alberton area. But I'm not going to repeat Mr. Bushy's comments. I think he's expressed his concerns eloquently. I guess the concern I would have, and anyone on the panel can certainly comment to this, is the trend I'm seeing not only tonight but on the screen and on the banner of tying in quality and safety into the message that we're hearing now. And I have a concern about that in that I don't think that if we're going to look at safety, I think that's begging the question or implying that perhaps there's currently an unsafety or something unsafe in the system at present. And I don't see that. And a fear that I would have is whether or not we're using that as a vehicle to take us down a path or a motive that's not justified, perhaps in the interest of cutting costs. Specifically with the dialysis units, we've heard the argument that, well, there's something unsafe about it. I don't think that's true. I don't think there is anything unsafe. And I would just express some concern that we tie that word in too much in the argument. Certainly, nobody in this room or in this province wants to be a victim of unsafe care. That's not what I'm advocating. But there's more to quality care than safety. And for one, accessibility, I think, is something that most people in this province would see as being an important aspect of quality care. Accessibility to doctors, accessibility to dialysis units, for example, and I don't think that they're at competing odds. And if anyone wishes to comment on that, I'd certainly leave that open. But to rely on an argument of safety where there are no safety issues to achieve a different or an ulterior goal, I would express some concern about that. And I think we've seen that perhaps used not too long ago, about half an hour west of here in the Bonshaw-Churchill area to varying degrees of interpretation. If anybody wishes to comment on that, I'd certainly be interested in hearing some.
So comment from the panel. Donna?
Thank you, Matt, for that comment. And I think one of the things to reiterate is that as a board, the issue of quality and safety has been paramount from year one. That quality and safety are determined as the most important issues for us as providers. And when you put quality and safety as your key component or your core component, access and quality is part of that as well. It's not just quality and safety. There are 8 dimensions of quality that are considered. So to kind of reassure you and the audience that the putting quality and safety on our agenda is not new, but actually validating it as a key and essential component of why we're here and why we want to provide the best service possible. Now, is it always perfect? No. Are we continually trying to address safety issues? Yes. Are we trying to continually improve in the quality dimensions that, whether it's dialysis care or if it's hospital or surgical services or if it's long-term care services? Essentially, as a board, our priority is to provide the best quality service that all clients really require. And when you're doing one island integrated system based on quality, no matter what we do, there will always be difference of opinions about where the service should be provided, by whom, and with what resources. And I guess we'll continue to engage and dialogue with not just people like yourself, but with the population to identify what is the best for islanders.
Question from Peter. As we move towards streamlining and digitizing medical records, what provisions are being made for patient access to our own records?
Dr. Wedge.
There are a number of policies around patient access to the records, and both in terms of safety for the patients, there's appropriate use policies that are in place to make sure that health professionals aren't accessing records they're not supposed to. But certainly anybody, there are requests that can be made through the Health PEI towards either getting a copy of their records or checking to see who's had access to their digital record, and a printout can be made. And that does occur, I'm not quite sure how often, but at least every day, if not more often than that, from a number of patients. So I'm not sure, does that answer the question?
Thank you. That was one online question, so we'll soon find out. Okay, so we're going to go to mic 1, mic 2. I see one more person, then we really will have to reassess our time. And if you have a question that isn't getting answered, don't forget that you can submit it online on the web, and I have assurances from the board that every question will get answered, so don't panic if you can't get yours going. So mic 1.
My name is Sarah McDonald, and I'm from Surrey. I have 2 questions. The first one is, given the substantial investment that was put into the new manor in Surrey and the fact that the aging population is a pressure on the healthcare system, I'm just wondering why more beds weren't put into the new facility that were in the existing facility. That's the first question. And excuse me. The second question is for Dr. Baker. Sorry. Just wondering, the patient-run dialysis sorry. I don't know if you're aware of our current dialysis situation, but as you can probably tell, it's under threat of being closed, largely because of the financial situation, as far as I'm aware. So I'm just wondering, is that a viable solution for us financially?
So let's take the first question first. Who would like to address the question about the manor beds? Dr. Wedge.
I'm not sure if this mic is on, but yeah, the manor beds, there was a whole process around the renewal of the manors. There was a long-term care strategy and plan put in place. Cecil, did you want to comment on that?
There were 4 additional beds put into Colville Manor when the building was open. And I think then the decision was made to move to more investment in home care to support people to stay at home.
Okay, thank you. All right, and the question to Dr. Baker.
So dialysis is a critical service, but it's not a simple service, as Dr. Wedge was explaining. And I think the critical thing is to have the expertise there or to train patients well to do that. But I think exploring various ways to ensure dialysis services is the right thing to do, because that technology is changing and we can do things now in the home that we couldn't a few years ago. So it's an evolving game. So I agree with you. It's an important service, but I don't know the specifics of the service in your area.
Thank you. Okay, so I'm going to, sorry, in interest of time, I'll have to switch over to mic number 2 here in Charlottetown.
Good evening. My name is Paul Jenkins. I'm a pharmacist here in Charlottetown. I'm going to give Dr. Wedge a bit of a rest here at this point and ask Dr. Baker. With his expertise, I see numerous healthcare providers in the audience here this evening, nurses, physicians, home care providers, etc. What advice or examples could he give to us to take away this evening on seamless care for patients, both in the acute care setting and in the acute to community care setting?
That's an easy question.
You have 30 seconds, yeah.
No, I mean, I think this idea of seamless care is a great sort of goal for the system, and it's one that I think many people now see as important for reasons I talked about earlier. The devil is in the details, but what I was trying to communicate is that every system has to bring the resources to bear that it has around that, but it has to create an environment where it encourages local experimentation around these ideas and in a safe manner to figure out what works for PEI. What works for PEI is not going to be the same thing that works in downtown Toronto, but it's going to have some of the same elements. So it's the ability to figure out how to design new ways to deliver care that takes advantage of new technologies, potentially new relationships, and that really brings to bear the skills of the entire team. And pharmacy is one of the areas that we have really underutilized in our healthcare system. There's a lot of knowledge there that will be valuable. And just to take one example, you know, we have this phenomenon of patients leaving hospitals and going into home care. There needs to be a medication review, and there needs to be a pharmacy expertise that's available to the nurse or whoever does that in the home. And so that's an area that's just crying out for some local experimentation around that. Some work going on in that area in Ontario, and I think it would be very valuable to do that across the country.
Thank you. Okay, sorry about the timing, but I'm going to switch over to mic number 1, and then we've got one more question.
Hi, my name is Trent Glenn. I'm originally from North Rustico, but I live in Charlottetown now. This is sort of a personal question, but it's not. It's geared towards kidney disease. 12 years ago, I had a kidney transplant, and for when your kidneys get at 10%, they advise you, dialysis is coming up, kind of deal, whatever. But then they could test you, like they can test your relatives or whatever, see if there's a match. And that was fine. That was 10 years ago. Now they're saying it's a 3-year wait before they can get tested. And it is personal because I have family that, they have relatives that the blood match types, but they can't do, and I know other friends that have it too, that they can't get tested because it's a 3-year wait.
So question around the wait
And this is
time.
for somebody that's not on dialysis right now. This is somebody that's like in the 15th percentile, and they're preparing them for dialysis because it's a 3-year wait. I'm just inquiring, why is it a 3-year wait?
Dr. Wedge.
You raised
No, it has nothing to do with the units. No, this is not a dialysis question. This is like preparation for something else.
Yeah. You're exactly right. The ability of Health PEI to test patients and work them up towards an organ donation is not great on PEI. We did originally start with some nursing staff that were working with Nova Scotia towards that. The explosive growth in dialysis services, both in PEI and Nova Scotia, has meant that over the past year, Nova Scotia has stopped testing island patients. We've had a stable sort of one nephrologist system. We went to 2. Now that we've stabilized that and we've moved into the new units that have occurred at Prince County Hospital and Queen Elizabeth Hospital, now the time is to spend some more time on the organ donation plan. So we have a business case being developed now that's we're going to try and find the resources to hire actually a nurse to do organ donation workups for island patients who wish to donate living donors, what we call living donors, which I think is what you're aiming at.
Yeah, that's what I mean, living donors, yeah.
So watch for the news. It is coming. I'm not sure, I see Jamie is here, but probably the next month or so we should have some plan that's ready to bring forth to the public.
Great, thank you. Thanks. Okay, and final question of the night, at least here, but don't forget you can send your questions on the web.
Good evening. My name is Gilles Benoit. I'm representing the French School Board, and I'm from Summerside. I'm going to ask some question. I'm going to try in English in a way, and if I need the translator, please, translator, go ahead. So it's another issue. It's not that us French don't have health issue. It's just I'm going to ask question on another matter, and it's a three-item question, if I might say. LPI have done a lot to offer bilingual services to Francophone, and we really appreciate it. Some families do need French services to make sure they are understood from their health problem. Can we expect that LPI will continue to try to offer more bilingual services to the Francophone communities? That's my first part question.
Do you want to do all 3 parts and then we can deal with them? Sure,
Second part is in the East, since I'm representing the education system, we don't have the service of speech therapists in the East. And French families struggle to have services for their young kids. And you know how it's important that those young kids receive the services as soon as possible. Can we expect that that LPI will try to address, to offer that service to Francophone in the east of the province, since we have that services in the west. And my last question is probably I don't remember your name, I'm sorry. Could it be a safety issue of a patient not able to explain to his doctor or to the nurse his health problem in his own language, since he might struggle like I am to explain himself or herself in his own language? That's my three-part question. Thank you very much.
Thank you very much. So who wants to try the first two in terms of French services and speech therapy? Dr. Wedge.
So, French language services, we do have a French language services coordinator in Health PEI who works with various parts of the health system, basically whether it's primary care, acute care, long-term care, to try and beef up services where needed. So we do have that in place, and you're right, French is our second biggest language on PEI. We also, about a month or so ago, entered into a contract with a language interpretation service for both primary care and our emergency departments, where basically they offer about 30 languages almost on demand, so that if a patient arrives in the emergency room or in let's say our immigration clinic in Charlottetown, they can actually call the service and have a professional translator work with the families to do that. So whether it's in Punjabi or Mandarin or French, those are all available. So that system is rolling out across the province as we speak, and it just started in the last couple of months. So that's the kind of the direction we're going. Now, we have some problems in trying to figure out how to do this in the fee-for-service world, in private offices, because it's a contract with Health PEI, so we're trying to work out a few payment arrangements, I guess, to try to make sure that works. So that's the French language one. As far as the speech language pathologist, I'm not quite aware of that particular one. I don't know if anybody else here is either, but we do have speech language pathologists. So we have somebody in the audience that...
Any staff members who want to help there? Kathy.
Kathy. Oh, there.
We do, thanks Brad. We do share service delivery for speech language pathology with Department of Education and the school boards. The Health PEI SLPs will service preschool children, certainly both for preschoolers as well as for school-age children. As you know, Jill, has been a challenge because we have one sole bilingual speech language pathologist that has been based out of Wellington, but she is now prepared to travel at least to Charlottetown and start to see some children, both in the school system and in the preschool population. So that should be a help for now.
Thank you. And the last answer over to Dr. Baker.
Yeah, so I think it's pretty clear that communication is an important component of effective interaction between a patient and a physician or other caregiver, and so you're absolutely right. It's important for people to be able to communicate, and I'm glad that Dr. Wedge has indicated that there are efforts being made to provide professional level translation services. We've had a lot of experience with trying to find somebody who can fill in, who's not a professional translator, and that raises a lot of issues about confidentiality and skill and so forth. So I think the move to make that available, it's now one of the beautiful things about communication. You just have to be close to a phone. You don't have to have somebody who's in your geographic area, and these people are skilled and they understand the healthcare world. So I think it's a real positive thing.
Thank you. Thank you, folks. Kinsey, back to you.
I'd like to thank Verna very much for the work she's done. Sorry we've gone over time, but it's better to go over time and have some questions answered. Remember, you can always come out at us through the web. Two things have hit me this evening, and we just had them actually. One of them was communication, and the other was conversation. We've begun to talk about public engagement by conversation. conversation is two-way, communication is two-way, and we want to have more and more communication with Joe Q public so that we begin to get continuous input to Health PEI in the way we've had it this evening. Lots of issues, they're all worth asking about and they're all worth pursuing. Thank you for coming. Thank you to Dr. Baker for the effort he's made to be here and for the stimulus he's given us to think about high-quality healthcare systems. We'd like to think ours will become one if it isn't already on the way there. So keep challenging us, and we will keep trying to respond in the best way we can. Thank you to the panel, and thank you to all of you who have come tonight. So drive carefully as you go home.